I'm going to acknowledge that I am not the most technologically advanced person in the world, so please let me know if this looks weird. Does that screen look like a normal PowerPoint screen to everyone? Can I, Sarah?
Presenter mode.
It's in presenter mode? Okay.
Yeah.
It's, why am I not? Okay. Presenter mode and slideshow. So how about that?
There you go.
That looks better? Okay, perfect. You don't need to see my notes, right? So hi, everybody. I wish I could see your beautiful faces. I think just like patient care in clinic right now, not being able to like touch and see and hug and everything each other is a real loss. So Anna, Golob, and I are delighted to be presenting updates in ambulatory medicine to you all. This is what we look like when we're getting headshots taken. It's not what we look like right now when we're haven't had our hair cut in months and basically are wearing pajamas. But as you all know, Anna is the Assistant Program Director for Primary Care, and I'm the Associate Program Director for Primary Care. And we've had the great honor of doing this talk at the National ACP meeting a couple of times, but this year it was canceled, of course, so we were hoping to bring it to you. We have nothing to disclose. We are not going to be discussing COVID today, so hopefully that will be the last mention of that. So we looked at 37 articles and guidelines in 16 journals this year to come up with our update in general internal medicine, ambulatory general internal medicine. We basically read table of contents for most of these journals: Annals, BMJ, JGIM, JAMA, Lancet, and then looked through some of the other articles that were making press to bring this update to you. If you have questions, please put them in the chat. I can't see the chat from my presentation, but Anna will be moderating while I'm talking, and then vice versa. So hopefully it won't be too clunky. And Anna, if anything comes up in the chat that needs addressing right away, please just speak up and let me know. So we will be talking today about several things: hypertension, a few trials that came out, and some updates, Douaks, and more Douaks. It's been a bad year for Bayer again. Non-viral pulmonary illnesses. We're going to talk about buprenorphine. Good year to be a diabetic drug manufacturer. Lots of new updates in the newer diabetic medications, looking at bugs and drugs, and then some quick takes. So getting started on hypertension, I will review white coat hypertension, diastolic hypertension, whether or not hospitalists should be fiddling with outpatient hypertension regimens, and if there might be a magic pill to reduce cardiovascular risk. Our first case is Mr. Pili Coco. He's a 46-year-old man who presents for a routine visit in primary care. His blood pressures in clinic are 147/92 and 143/87. He reports that his blood pressure is always a little high in clinic, but is normal when he checks it at Safeway. So what are your next steps in evaluating Mr. Pili Coco for hypertension? Kind of think to yourself of what you would do for this gentleman. Do we say, he's just nervous at clinic and it's fine? Do we want more information? And if this is white coat hypertension, what is the long-term cardiovascular risk of white coat hypertension? This article came out in the Annals this year looking at cardiovascular events and mortality in white coat hypertension. It was a systematic review and meta-analysis of observational studies. So as one of my mentors in medical school used to say, garbage in, garbage out, but assuming the reviewers did not include studies that were not well designed. So the question they asked is, what is the long-term cardiovascular risk of isolated elevated office blood pressure, otherwise known as white coat hypertension? They included 27 studies. And among those were 25,000, almost 26,000 participants with untreated white coat hypertension or treated white coat effect. What's not totally clear to me is what's the difference between treated white coat effect and actual treated hypertension. But the treated white coat effect is people who have white coat hypertension and are on medication for it. And then 38,000 people with normal blood pressure, and they were looking at major adverse cardiovascular events, all-cause mortality, and cardiovascular mortality. The quick take on this is that white coat hypertension is associated with an increased risk of cardiovascular events, all-cause mortality, and cardiovascular mortality. Probably not a surprise to most of you that what we really need for Mr. Pili Coco is out-of-office blood pressure monitoring. So that's crucial in the diagnosis and management of hypertension. Taking someone's word for it that their blood pressure is fine at home is not really the safe way to go forward. So the gold standard, as you all know, is ambulatory blood pressure monitoring. But if that is not available to your patients, what the American Heart Association recommends is twice a day blood pressure monitoring, sort of morning and night, same time every day for a week. And then a quick return to clinic, either for a nurse visit or a provider visit to review the blood pressures from twice a day monitoring for a week. We'll pause here to see if there are any questions, Anna, that need to be addressed right now. Nope, we're good. Cool. All right, Mr. Pili Coco is returning to review the results of his 24-hour blood pressure monitoring. His average daytime blood pressure is 127/91, and his average nighttime blood pressure is 115/85. And he wonders, does he need to start on medication? Because he'd really rather not. So think to yourself about whether this 127/91 and 115/85, so really blood pressure is higher, his diastolic is too high during the day and too high at night. What would you do, primary care doctors? What do we know about the cardiovascular prognosis of people with isolated diastolic hypertension? So this article came out in JAMA this year looking at two questions. One is actually when the ACC and AHA updated blood pressure guidelines in 2017 to actually include more people, what happened to the prevalence of isolated diastolic hypertension, and what is the cardiovascular prognosis of folks with isolated diastolic hypertension by 2017 guidelines. This is a cross-sectional analysis of NHANES and another large data set, basically looking at people from 1990 to 1992 and following up in 2017, and then they validated against two large other external cohorts. All that to say that it was pretty rigorously done. Almost 10,000 adults from NHANES who are middle-aged and slightly more than half women, and 8,000, almost 9,000 adults from ERIC study, which also middle-aged, slightly more women. Looking at prevalence of isolated diastolic hypertension and then incident ASCVD events, heart failure, and chronic kidney disease. So surprising exactly nobody, the prevalence of isolated diastolic hypertension based on 2017 guidelines went up by about 5% based versus the JNC7 guidelines. So defining hypertension more conservatively will increase the prevalence. However, there's no difference in incident ASCVD risk, heart failure, or chronic kidney disease compared with normotensive controls based on the new definition of isolated diastolic hypertension. So you can see the graph here that compared with the normotensive controls, the IDH was not associated with these adverse events. The results were also null for cardiovascular mortality with the two external cohorts that they tested them against. This might not be generalizable to young adults. So the cohorts were generally middle-aged folks, and I often see isolated diastolic hypertension in my younger patients, so wondering if someone in their 20s who has isolated diastolic hypertension might have a slightly different risk profile than someone who's in their 50s with isolated diastolic hypertension. But the conclusion from this study is that the prevalence of isolated isolated diastolic hypertension obviously went up when they changed the definition, but that does not change any increased risk. That doesn't account for any increased risk for cardiovascular events. Any questions about that? So thinking about Mr. Pili-Coco, you can think to yourself whether you would want to treat him. It's probably not necessary from a cardiac risk side, but always encouraging my patients to eat a more plant-based diet, try to move their bodies as much as they physically can, and avoid other risk behaviors like smoking. All right, our next case, Mr. Soldat is an 82-year-old man with a history of hypertension and diet-controlled diabetes. He's hospitalized for acute diverticulitis. And while inpatient, his blood pressures are consistently in the 150s over 90s. The hospitalist increases his amlodipine from 5 to 10 and his lisinopril from 10 to 20 on discharge, really feeling like they're doing you a favor as his primary care doctor. Since discharge, his blood pressures have ranged from 103 to 125, over 62 to 79, and he wonders if he should stay on the medications as they were prescribed on discharge or go back to his previous doses. So think to yourself for a moment about what you would do for Mr. Soldat, 82-year-old, pretty healthy guy. So the question in this upcoming study was about whether cardiovascular outcomes are improved when patients' antihypertensive regimen are intensified during possible admissions for non-cardiovascular reasons. And this has gotten some attention. Many of you have probably seen this one already, published in JAMA Internal Medicine. And it was a retrospective cohort study of veterans, about 4,000 hospitalized veterans with hypertension. So they're generally pretty elderly and 98% men. And the exposure that they were looking at was discharge with antihypertensive intensification after a non-cardiovascular admission. Outcomes are hospital readmission, serious adverse events, cardiovascular events, and change in systolic blood pressure within 1 year of discharge. So think to yourself, if you don't already know this study, what you think the outcome of this study might be. And what we can see here is readmissions, serious adverse events, and cardiovascular events. The results are that within 30 days, patients receiving intensification of the antihypertensives had a higher risk of readmission, a higher risk of serious adverse events, no difference in cardiovascular events at a year, and no change in systolic blood pressure at a year. Obvious limitations, this is a retrospective cohort study. It's elderly population, it's virtually no women. So does this stand true if somebody's 45 years old and a woman, not a veteran, if someone has more chronic disease? But the conclusion from this study is that among older adults hospitalized for non-cardiac conditions, intensification of antihypertensives was associated with worse outcomes. Of interest, another study has come out since Anna and I put this presentation together, demonstrating something very similar with diabetes, insulin, or diabetes medication intensification, especially for people whose A1C is pretty well controlled as an outpatient. If someone's blood sugars are high as an inpatient and they have an A1C of 7 as an outpatient, we probably shouldn't be doing anything drastic to their insulin regimen other than making sure that we're treating their blood sugars to avoid acute complications in the inpatient setting. Any questions about that before we move on to the next article? No?
Marianne, there's just a few chat items going on, but I think they can probably wait until our sections switch.
Okay.
Yeah.
All right, I'll move on to my last article for this section. So Mr. Soldat, our delightful 82-year-old veteran, he's returning 6 months later for a routine visit. He endorses feeling tired of having to take so many medications every day, and he wishes there were a magic pill he could take to manage all of his chronic conditions at once. Wondering if there is a magic pill, would it work? And all of you can think about what would you put in that magic pill. So think for a moment to yourself, if you had a magic cardiovascular prevention pill, what would you put in it? This was an interesting article in the Lancet in August, from August of last year, looking at the effectiveness of a polypill for primary and secondary prevention of cardiovascular disease. This was a study done in Iran. It was cluster randomized trial. So they basically clustered the groups by villages and randomized them to either sort of a minimal care group, which included a package of non-pharmacologic preventive interventions, sort of lifestyle coaching, plus whatever their primary care doctor was providing for them, or a once daily polypill tablet plus the non-pharmacologic intervention, so the lifestyle coaching. And the polypill included aspirin, atorvastatin, hydrochlorothiazide, and either an ACE or an ARB. They were looking at hospitalization for ACS, fatal MI, sudden death, heart failure, coronary artery revascularization, and non-fatal and fatal stroke. What do you think happened? What they found was 301 events in the minimal care group, so 8.8% event rate, 202 events in the polypill group, so 5.9% event rate, so adjusted hazard ratio of 0.66. They did a subgroup analysis of high adherence to the polypill, so people who were taking it, I think it was 85% of the time or more, and found that among that group of people, the hazard ratio was 0.43. However, that wasn't a predetermined subgroup analysis, so take that all with a grain of salt. There was no difference in brain bleeds, and slightly more, but not statistically significantly more, upper GI bleeds in the polypill group. Limitations of this one, a single country study with potentially slightly different disease risk factors. I don't know the rate of smoking and things like that in Iran, and the baseline rate of cardiovascular disease. And also their polypill, this was done before new aspirin guidelines. So it includes aspirin, which we would no longer use for primary ASCVD prevention for the most part. So wondering what would this look like without aspirin involved. Conclusion of this, though, is that this polypill was effective in preventing major adverse cardiovascular events, and the adherence was generally high and adverse events were generally low. So I think for our purposes, this is more of a interesting theoretical question, but I think for those of us working in, planning on working in low resource settings or low and middle income countries, a polypill strategy could be considered as an effective component in controlling and preventing atherosclerotic cardiovascular disease. So our take-home points: white coat hypertension is associated with an increased risk of cardiovascular events, all-cause mortality and cardiovascular mortality. Out-of-office blood pressure monitoring is crucial in the diagnosis and management of this hypertension. Isolated diastolic hypertension is not associated with an increased risk of cardiovascular events. Among adults hospitalized for non-cardiac conditions, intensification of antihypertensives and diabetes medications at discharge is associated with worse outcomes. And this polypill used in Iran demonstrated acceptable safety and efficacy, and that might be a reasonable strategy to control cardiovascular disease, especially in low and middle income settings. So that concludes our hypertension update for 2019 to 2020. Anna is going to take over, if I can stop sharing my screen. She will start sharing her screen and we'll switch places. So I'll be moderating the chat and Anna will take over the talk.
This is where our tech limitations come front and center. So let's see. I'm gonna start sharing my screen. Oh gosh, lots of options here. Let me go to my PowerPoint. Also, you guys feel free to stretch, wiggle as you need to at home or wherever you may be. Okay, so, whoops. Okay, do you guys see about Mr. Palpitation here?
Yes.
Okay, thank you, Marianne, for
Sorry,
validating.
I realize I'm the only one who
I
you
know,
can hear.
like, thank you for validating. So yeah, I will be happy to also address any questions that come up regarding this section after I'm done speaking and we switch again. And of course, Marianne will be looking at the chat, so keep the questions coming. It's really, we would love this to be even more interactive, but we're gonna do our best. So let's start talking about Douaks. This is the first of 2 DOAC roundup sections in this talk because this is one of my favorite drug classes. I'm sure it's yours as well. So we just need to talk a lot about Douaks. All right, so let's focus on the case. So this is Mr. Palpitation, who's coming into the ED with escalating chest pain and is admitted to the hospital with an NSTEMI. He has a medical history including type 2 diabetes, stage 3 kidney disease, and Afib on Apixaban. He successfully undergoes stenting to his right coronary, but as he prepares for discharge, he gets a little bit nervous, starting to hear about all the different blood thinners that are being discussed for him. And so the question that we're reviewing here is, given that he has a history of AFib, is already on Apixaban, and now has just had a stent, what is the appropriate antithrombotic therapy for him to take at the time of hospital discharge? And so the background here is that this population of folks who have multiple indications for antithrombotic therapy are at particularly high risk from all these blood thinners, but we would love to find a way to safely treat them without excess bleeding risk, but still preventing the ischemic events that they're at risk for. So that's kind of the holy grail in this field. And there have been many recent trials looking at this specific population in recent years. For each of these trials, the traditional triple therapy, sort of the old way of doing things, which was warfarin plus clopidogrel or P2Y12 inhibitor plus aspirin, so triple oral anticoagulant therapy, is compared to some newer regimen that's perceived to be at lower bleeding risk. And the idea is to test that, make sure that that is true and also safe, that there are less, or there's not more ischemic events. So the trials that came out in recent years, the WOAS trial back in 2013, looking at just dual therapy, warfarin and clopidogrel, Pioneer AFib, PCI 2016, looked at a low dose rivaroxaban regimen plus clopidogrel, and then the redual PCI 2017, looking at dabigatran plus clopidogrel. And what all of these trials found is that this newer regimen was safer and non-inferior to triple oral antithrombotic therapy. So that's sort of where we were, and then enter the trial that we're going to be discussing today, which is the Augustus Trial. So this came out just over a year ago in April of 2019, published in the New England Journal. And this is sort of the grand poobah of this type of trial. So we'll go through what they did here. Basically, the author's question is, what is the safety and efficacy of Apixaban versus warfarin? So looking at DOAC versus vitamin K antagonist. And also, what is the efficacy of triple therapy versus dual therapy in patients who have this scenario of having AFib, needing to be anticoagulated, but also having an ACS event or a stent event? So they designed this as a prospective 2x2 factorial randomized trial. They enrolled 4,600 adults who had AFib, needing long-term anticoagulation, who had an acute coronary event, which was either treated medically or treated with stenting, or who had an elective stent. And it turned out to be about a third for each of those categories. So a third were ACS treated medically, a third were ACS stented, and a third were elective stented. And then they had to have been planned to get at least 6 months of a P2Y12 inhibitor. For 92% of those patients, it was clopidogrel, so I'm just going to call it clopidogrel going forward. So the intervention arms, as I mentioned, there's 4 different arms. I'm using my little pointer here. So half the patients are going to get Apixaban, and for a half of those, it'll be Apixaban as part of the dual regimen with just Apixaban and clopidogrel. But the other half of the Apixaban folks are getting triple therapy, so Apixaban, clopidogrel, and aspirin. And then the other half are going to get warfarin, again, either as part of a dual with just clopidogrel or a triple therapy regimen with warfarin, clopidogrel, aspirin. So lots of useful comparisons here. Their outcomes, the primary one was actually a safety outcome, so they're looking at major and non-major but relevant bleeding per International Society for Thrombosis and Hemostasis criteria. And then secondarily, they're looking at a couple of different composites. Firstly, a composite of death or hospitalization, and secondly, a composite of death or ischemic events such as stroke, MI, stent thrombosis. So what did they find? First, I'll draw your attention to part A of this figure. So this is just showing, again, how did the folks do with regard to bleeding, and what you probably guessed is that they found clearly that the folks getting Apixaban as compared to warfarin had less bleeding. So hazard ratio here is 0.69, which met significance. How did the people do getting triple therapy versus dual therapy? No surprise, being on triple therapy, so adding in that aspirin, almost doubled the risk of bleeding. So again, not too surprising based on other studies. And then they nicely calculated sort of what was the bleeding event rate per 100 patient years for folks in each of these regimen categories. So clearly least offensive was the Douaks plus clopidogrel dual therapy with about 17 bleeding events per 100 patient years. And then the worst offender being the old school, the old guard, warfarin plus clopidogrel plus aspirin with 50 events per 100 patient years. And what you can see is that adding in that triple therapy basically doubles the bleeding risk compared to the dual therapy, the similar dual therapy regimen. So that was the safety outcome, but how did they do with regard to ischemic events? Because those are the things that we're also trying to prevent with these agents. So when it came to their secondary outcomes, let's first talk about the Apixaban versus warfarin comparison. With regards to death or hospitalization, the Apixaban folks actually did better. So hazard ratio here is 0.83, which was significant. So this was largely driven by less hospitalizations in the Apixaban folks. When it came to death or ischemic event, here there was a little bit of a trend toward less of these with Apixaban, but it did not meet significance. So useful trend, not fully significant. What about triple therapy with aspirin versus dual therapy? Well, here it's interesting. They didn't find any significant difference in these two outcomes. However, I will say there was a trend toward less ischemic events, in particular with the aspirin folks. So clearly there's a little bit of a thrombotic cost when you don't have people on triple therapy, but that comes along with it quite an increase in bleeding risk. So what are the conclusions by the authors for this Augustus trial? Well, for patients who have this scenario of AFib and an acute coronary event, which is stented or treated medically or have an elective stent placed, the combination of just Apixaban plus clopidogrel did appear to be safer and non-inferior to triple therapy or dual therapy with warfarin. Limitations to be aware of. This study just really wasn't powered to detect significant differences in individual ischemic events. So, even though there was a signal that there was a little bit more MI and stent thrombosis in the people who weren't getting aspirin, it wasn't enough to really meet statistical significance. That being said, I would say I am still seeing cardiologists locally discharge people on triple therapy regimens, but they're doing it for shorter periods of time. I think the guidelines have not had a chance to address Augustus yet, but I think this is coming, and I think we're going to see shorter and shorter triple therapy regimens, although some people maybe a dual therapy regimen right out the gate as people start to take up this evidence from this trial.
Hey, Anna, can we pause and ask
sure.
everyone to mute their mics? Whoever just got either into or out of their car and either zipped up or unzipped something, we can hear everything you're doing.
Thank you. All right, so I will again take questions or I'll respond to questions after this section, but I want to move on to the next awesome Douaks trial. So back to Mr. Tation, he is grateful to leave the hospital on only 2 blood thinning agents, Apixaban and clopidogrel, because his providers are early adopters of trial-generated data. He does well, has no further chest pain, resumes his active lifestyle, and he comes in to see his PCP 1 year later and says, hey, how long do I actually need to take this clopidogrel anyway? Because it's, kind of costly and all that kind of stuff. So here we're going to address the question, what is the appropriate antithrombotic therapy for patients who have AFib and stable coronary disease? So I just shared with you that there's been a flurry of activity in the immediately post-cardiac excitement patients who have AFib and what to do with their blood thinners, but there had been relatively little data apart from observational data in how to manage people who had long-term stable coronary disease as well as AFib. So enter the AFIRE trial published last September, also in the New England Journal. And again, this is sort of the first randomized trial looking at best practice for antithrombotic therapy in patients with stable coronary disease and AFib. So what the author's question here, they looked at rivaroxaban. So is rivaroxaban monotherapy non-inferior to rivaroxaban plus an antiplatelet in patients who have both AFib and stable coronary disease? They designed this as a multi-center randomized but open label trial. So the study participants, the providers could choose which antiplatelet agent they wanted to use. And also this is a one country study. So all of these centers were in Japan. So the population included 2,200 Japanese adults who had AFib and angiographically confirmed coronary disease, who may or may not have had stenting or CABG, but all the excitement had to be at least a year before enrollment in the trial. Their intervention arm was full therapeutically dosed rivaroxaban monotherapy, and their control arm was rivaroxaban with an antiplatelet. Again, this could be aspirin or clopidogrel per the provider's choice. It ended up being 70% of these folks got aspirin, and the other 30% or so got clopidogrel. Their primary outcome was a composite of ischemic events, basically stroke, embolism, MI, unstable angina, or death. And then they also had a safety outcome, which was major bleeding. So it ended up that this study was stopped early after 23 months, and I'll get to why that is in just a short minute. But first I want to focus on their safety outcomes. So not a surprise, they found that rivaroxaban monotherapy was better when it came to bleeding with a hazard ratio of 0.59. So not a huge surprise. What was a little bit surprising is their primary outcome, which is this, again, composite of cardiovascular disease events and mortality. Here, though, they were looking for basically no difference, or maybe the aspirin folks would have done better. It actually turned out that rivaroxaban monotherapy group did better. And so hazard ratio of 0.72, which even met significance for superiority, although again, that's not what they were looking for and not what this was designed to look at. So let's break that down a little bit. So the first thing you'll see that's better in the rivaroxaban monotherapy group is less hemorrhagic stroke. And that actually makes sense. So they're on less blood thinner, they're going to have less brain bleeds. Great. But what was more of a surprise is that folks in rivaroxaban monotherapy had less deaths. And this was applicable to cardiovascular deaths, including heart failure, as well as non-cardiovascular deaths such as cancer and other causes. And again, this wasn't expected, and there's not a great physiologic mechanism for why that would be. So a little bit of a surprise. And ultimately, this is why the study was stopped early. So just to kind of round up what the findings were, basically the authors felt confident in saying, yep, it's safer to have DOAC monotherapy in these folks with regard to a bleeding risk. They also concluded that it was non-inferior with regard to ischemic events and deaths to have patients on monotherapy. They did not go as far as to say it's clearly superior, so they didn't make that stretch. But this really gives me something to chew on, some pause, because I have a lot of patients, as I'm sure you do as well in your panels, who really meet this criteria. They have AFib and they have boring, stable coronary disease where nothing exciting has happened in a very long time. And I think it's really interesting to think about transitioning them to DOAC monotherapy. Guidelines are still not yet updated on this subject, but I think we're going to be seeing that coming. I will just remind you that limitations do exist here. This was a single study in a single country, and it wasn't blinded with regard to which antiplatelet was, or wasn't blinded, and they had some options regarding antiplatelets, so you can't say the issue is because it was aspirin versus clopidogrel. And also remember, the trial was stopped early, which can overestimate treatment effect, but definitely interesting. So I want to move on to the third AFib trial we'll be talking about today. And so this is regarding AFib and alcohol use. So our patient, Mr. Tation, who's aspirational, asks us what lifestyle changes he can make to reduce his burden of AFib. So we're going to be briefly talking about this article that caught my attention in January, also in the New England Journal of Medicine, looking at alcohol abstinence in drinkers with AFib. And there's some physiology to back up the author's interest in this question, because there's been sort of this observational effect seen that more alcohol tends to cause more AFib. Okay, so looking at this trial, the authors are asking, what is the effect of abstinence from alcohol on secondary prevention of AFib? They designed this, and this was an Australian study, by the way. They designed this as a multi-center prospective open-label trial. They enrolled 140 adults who had paroxysmal or persistent AFib and were drinking at baseline at least 10 drinks per week. So they're hoping to find sort of a heavier drinking population or actively drinking population. Just to share, at baseline, these groups were drinking about 17 drinks per week. And they had to be in normal sinus rhythm at the time of enrollment in this study. So these weren't people who were chronically in AFib. They also tried to exclude patients who had alcohol use disorders. They really wanted to get a population they felt would be successful in reducing their alcohol use. The intervention was asking them to abstain from alcohol use, and then the control arm was continue your current use. And the outcomes they were looking at were freedom from recurrence of AFib during the study, as well as what was the total burden of AFib during the 6-month study period. And so what did they find? Well, this is impressive to my primary care heart. The reduced drinker group actually got average alcohol use down to 2 drinks per week, which is quite exciting change, and the continued group averaged about 13. Clearly, you can see there's a difference in recurrence of AFib. So about half of those in the abstinent group had recurrence of AFib versus closer to 3/4 in the continued use group. And then there was about double percentage of time spent in AFib over the 6-month study period. And I didn't mention this to you, but they used a variety of cardiac monitoring techniques and devices to evaluate whether people were in AFib status, and that included implantable cardiac monitors. Some of them had already, versus they had a pacer and ICD device, or they were also using smart technology with apps that were sending in twice daily EKGs. So that is, I think, ultimately a little bit compelling data to share with our patients, that they can really potentially reduce their burden of AFib by reducing alcohol intake. Okay, so that is the round 1 of Douaks. I'm going to pause there and turn it back over to Mary Ann, and also start studying the chat.
And I think because you're so brilliant and clear there, I am not seeing questions coming through on the chat. But if anyone has any questions for Anna, please start adding them to the chat now, and I will try to take over the screen. All right, how does that look to everybody? Good? Good.
It's in presenter mode again, Marianne.
Again, dang it. Is that still in presenter mode?
No, that's perfect.
Okay, great. Thank you for helping me. I'm so old. I feel so old when these things happen. All right, so we're going to talk about lungs. I love lungs. And a few trials and updates that came out this year. First one is about point of care CRP testing, the IDSA and American Thoracic Society guidelines for management of community-acquired pneumonia. lung cancer screening trial that came out of Belgium and Netherlands, and then one little from the Wayback Machine. Remember before that virus that shall not be named, we were all very worked up about vaping-associated lung injury. So we're going to just briefly review that because it would not be a year in review without talking about that old news. Our case is Mr. Ralph Latu, who's a 63-year-old man with coronary artery disease, with gold stage 3 COPD, hypertension and depression, and he's smoked a pack a day since he was 20. He presents to clinic with a 2-day history of worsening shortness of breath, increased cough, and increased yellow-green sputum. He's currently using inhaled Olotio once daily and albuterol 4 times a day as needed. And he's feeling pretty miserable, but is worried about the amount of antibiotics and steroids he's received for his COPD exacerbations over the past year. So just think about what you would do for Mr. Latu for a moment. He is coming in with shortness of breath, cough, and increased sputum, sort of meeting all 3 criteria for a COPD exacerbation. Let's assume his oxygen saturations and vitals are stable. So wondering, is there a lab test available to help guide the treatment for Mr. Latu's COPD exacerbation? This trial came out in July in the New England Journal, asking about whether point-of-care CRP testing could reduce the unnecessary use of antibiotics in patients experiencing an acute COPD exacerbation. Kind of an interesting trial, 650 patients, all middle-aged or older, experiencing an acute exacerbation. This was done in England and Wales. And the intervention was checking a point-of-care CRP versus usual care. And the guidelines that were provided to the CRP group were that a CRP less than 20 would indicate that antibiotics are unlikely to be beneficial. A CRP 20 to 40 demonstrate that antibiotics may be beneficial if the sputum is purulent, and CRP over 40 would strongly suggest that antibiotics should be used. It was a multi-center, open-label, randomized controlled trial. There were something in the order of 90 or more clinics, if I'm remembering correctly. And the outcomes were patient-reported use of antibiotics for acute COPD exacerbation within 4 weeks after they had their initial visit, and then the COPD-related health status 2 weeks after they were randomized. What they found is that a lower percentage of the patients in the CRP guided group received antibiotic prescriptions at their initial consultation. So about half of the CRP group got antibiotics, and about 70% got, in the usual care group, got antibiotics. The adjusted odds ratio for getting antibiotics if you were in the CRP group was 0.3. The CRP group reported less antibiotic use than usual care at the at 4 weeks follow-up and at the first visit, obviously. So 57 versus 77%, and then 59 versus 79%. Patient-reported COPD-related health status at 2 weeks after randomization actually favored the CRP group, so the people who got antibiotics or not based on this lab test. And 2 patients in the usual care group died of unrelated causes, so did not thought to have anything to do with this trial. So interesting, the CRP group, CRP-guided antibiotics for COPD exacerbation seem to reduce unnecessary antibiotic use without causing harm. The big obvious limitation in this is who in the world has a point-of-care CRP test in their primary care clinic. And this study was funded by Abbott, who makes this Affinion desktop device for CRP point-of-care testing. So obviously all the devices were provided to the clinics for free, just loaned out during this study period. So I think this is kind of an interesting idea, but again, if we don't have the test available, it doesn't really help us. And I don't think, for me, getting a CRP test, which would come back to me much later than the patient would even be in clinic anymore, would change anything. But I think future state, if this were something that were suddenly available, might be an interesting thing to explore. So Mr. Latu has recovered from his COPD exacerbation, is considering your advice to quit smoking. He returns 5 months later with fever, productive cough, and a right lower lobe opacity on chest x-ray. His oxygen saturation is 92 on ambient air, and his vital signs are otherwise normal. So you have a few questions. Does he need to be admitted? Should you get a sputum sample? What antibiotics should you prescribe? And does he need a chest x-ray to follow up in 4 to 6 weeks? And you remember in the back of your mind somewhere that IDSA and ATS came up with new community-acquired pneumonia guidelines, but you haven't had time to read the 9,000-page document. So I will share some things for you. What are the changes to the IDSA ATS guidelines for adults with community-acquired pneumonia? And there are lots and lots and lots of recommendations. I'm going to focus here on just the ambulatory things, the things that really are kind of relevant to our primary care practice. And the changes are that for adults without significant comorbidities, you can use amoxicillin, doxycycline, or azithromycin monotherapy for sort of straightforward community-acquired pneumonia. You want to adjust for resistance patterns. Obviously, if there's a high macrolide resistance rate, you want to adjust for that. For adults with significant comorbidities, you should use amoxiclav or a cephalosporin plus a macrolide or a respiratory fluoroquinolone. So it'd be people who have diabetes or significant coronary artery disease or otherwise just sick. They looked at the use of different prediction scales and recommended pneumonia severity index over CURB 65. For me, this is a little bit impractical just because I don't always have like a CMP to look at somebody's labs before I'm making the determination about where they should go, whether they should go to the ER, get admitted. So I often will just use the CURB 65. It's not that much worse than PSI if I don't have all the data that I need for the PSI. But in general, try to look at a prediction tool when you're thinking about how to triage a patient with community-acquired pneumonia. And then the duration of treatment should be guided by normalized vital signs, ability to eat, and normal mentation, and no less than 5 days. But if someone's feeling better at the 5-day mark, they're eating okay, their vital signs are okay, they're thinking okay, they're keeping up with their I's and O's, then they can stop antibiotics at the 5-day mark. For otherwise healthy-ish people who are not getting admitted to the hospital, you don't need to obtain a sputum gram staining culture, don't need to get blood cultures, you don't need to be getting pneumococcal antigens or Legionella antigens. We're not using procalcitonin. I know that was a hot topic a couple of years ago, the CRP of 2018. But we're not using procalcitonin to guide treatment. Don't use corticosteroids. And this one for me was a potentially practice changer. Don't order the follow-up chest imaging if the symptoms have resolved and someone's not otherwise eligible for lung cancer screening. So in general, I've always had my practice to do a follow-up chest x-ray in 4 to 6 weeks for my high-risk patients, people sort of middle age and above, people who've been smokers, people who I would think might be at risk for lung cancer. And this guideline says don't do that. Get a chest CT to screen for lung cancer. We need to decouple the ideas in our mind. But if someone's young, healthy, and otherwise getting better, don't need to do that. So Mr. Latou returns to see us in 6 weeks. He's completed his treatment for CAP. He's feeling better. And at your advice, he's here to discuss lung cancer screening because, we should be screening this gentleman for lung cancer. So what are your recommendations regarding lung cancer screening? Does everybody remember the guidelines for lung cancer screening? You can add it to the chat box if you want to. So it's 55 to 75/80, depending on which guideline you look at, with 30-pack year smoking history, has either still smoking or quit less than 15 years ago, and would be otherwise well enough to withstand some form of treatment. Although, as Scott Hagan mentioned yesterday, brilliant Scott Hagan, people deserve to know what their diagnosis is, even if they're not going to get treatment. So if somebody wants to know, probably reasonable to offer them lung cancer screening. And this new trial came out in February, looking at reduced lung cancer mortality with volume CT screening in a randomized trial. And this came out of the Belgium and Netherlands. The difference between this trial and what has been done in the United States is 2 things. One is the interval frequency of the screening was less frequent and fewer screens. And the other thing is they were looking at volume of nodules and not diameter of nodules, or yes, diameter of nodules. So they had 13,000 men and then 2,500 women that they basically just decided up front to put in a subgroup because the number of women was low, between the ages of 50 and 74, who were current or former smokers, and the exclusion was someone who was moderately or severely ill otherwise, who had already had diagnosis of lung cancer, or they'd already had a chest CT in the past year. So they screened at baseline at year 1, year 3, and year 5.5 versus no screening, and looked at lung cancer mortality, all-cause mortality, and incidence of first recorded diagnosis of lung cancer. Results here, very high adherence. It's amazing what universal healthcare will do for you. Almost 88% of the male participants underwent at least 3 of those screenings. There was no significant difference in all-cause mortality. There were higher rates of lung cancer detection in the screening group, so lung cancer incidence here, and in general, that happened right away, so within the first 2 screens. And the lung cancer mortality was significantly lower in the screening group. So the cumulative rate ratio of death was 0.76. And what this did was lead to a substantial shift to a lower stage cancers at the time of diagnosis, so that they were more likely to get treatment in a timely way and survive the treatment. A post hoc analysis of women showed an even more favorable effect. And this is consistent with American trials that show that women actually benefit potentially more from lung cancer screening than men. The cumulative rate ratio of death from lung cancer was 0.67 for women. So in general, the case rate was pretty low. So of this group, there were 868 people, basically 860 people in each group who died. Lung cancer detection was 344 in the treatment group versus 304 in the control group. And the death rates from lung cancer, 160 in the treatment group and 210 in the control group. So the absolute rate of death if you got diagnosed with cancer was 18.4 versus 24.4. So that is lung cancer screening. I don't know that it's going to change anything for us right away because our radiologists generally are not doing volume-based nodule measurements, but does make me wonder if maybe we could change the frequency of screening, if doing it every other year for screening purposes is as effective as doing it every year. Sorry, there's a code green at the VA in case anyone cares. So that is lung cancer screening. I do think Mr. Latu needs to get screened, especially in a setting where there is adequate follow-up and treatment options available to him, such as ours. And finally, Mr. Latu is returning for follow-up, and he's tired of feeling so terrible. He really wants to try to quit smoking again. And he says, "Doc, I've heard that vaping might help me quit, but I've also heard it might kill me. What do you think?" So what do you recommend to him regarding the use of e-cigarettes and vaping to help this patient quit smoking? Is it the lesser of 2 evils? Is it harm reduction? Is it just trading one dangerous vice for another? So if you can think back to like August, September of 2019, we were all very excited about e-cigarette use and vaping associated lung injury. This original article came out in New England Journal about this pulmonary illness that was related to e-cigarette use in Illinois and Wisconsin. Basically finding a little more than 50 patients who reported e-cigarette use and developed this acute respiratory syndrome with bilateral pulmonary infiltrates that were not infectious or cardiac or rheumatologic or neoplastic. Most of these were male and white, and this may very well have to do with who's actually vaping. Median age was 19. 80% had used a THC product. 98% had respiratory symptoms. everybody had constitutional symptoms. 95% of those were hospitalized. Most needed supplemental oxygen. More than half needed ICU care. A third were intubated. So at that time, there was this emerging series of cases of the severe respiratory illness related to diverse e-cigarette exposure, and nobody quite knew what was going on. This is what people's imaging looked like. Scary. And as of February 18th, there were 2,800 hospitalizations and deaths, 68 deaths in 29 states and Washington, D.C. Basically cases in all 50 states and Puerto Rico and the U.S. Virgin Islands, so it was very widespread. And the common denominator, we think, might be vitamin E acetate in the vaping liquid. It was in a small trial found in 48 out of 51 BAL samples of E-Valley patients, so 94%, compared to none in healthy comparators. So there weren't any other smoking guns found, so probably vitamin E, although it was such a small study that we can't say for sure. CDC is no longer updating this and no longer tracking it, so we don't know if this has continued, and obviously as of February 18th we had other fish to fry, but the CDC recommendations is do not use vaping products that contain THC, and since not all contributors are known, the safest course is to avoid all vaping products, period. Now, one could argue that vaping could potentially be less dangerous than combustible cigarettes, but given the experience over the past year, I would not recommend it to Mr. Latu for smoking cessation. So our take-home points here, one is that CRP-guided antibiotics for COPD exacerbation resulted in lower percentage of patients reporting antibiotic use and no evidence of harm. To be continued to see if CRP point of care testing becomes something that we all want to invest in. The IDSA ATS guidelines have been updated, so you can review those, but in general, for patients who aren't otherwise highly morbid, you want to use amoxicillin or a macrolide. And use a severity scale to predict the prognosis, and you might be able to shorten the duration of treatment based on the patient's normalized vital signs and just general functioning. This new trial out of Netherlands and Belgium showed that low-dose CT screening decreased frequency led to earlier diagnosis of low-stage lung cancers and decreased lung cancer mortality. No changes in all-cause mortality, of course. And finally, vaping-associated lung injury might be caused by the additive vitamin E, and we should encourage our patients to avoid vaping, especially THC-containing liquids, and absolutely not liquids that someone's buying out of the back of a truck. I mean, if they have to get it, they should go to a reputable source. So I'm going to have Anna take over again. I will stop sharing. We'll get back to Anna.
Yeah, and there were just a couple questions about antibiotic use. I think Alana and Janaki both had a question.
Yes. Okay. Let me see if I can pull up the chat here. What were your? Let's see here. Alana's question: is this cap antibiotics or doxyazithro? Sorry, I'm going back. Just include azithro in the antibiotic use. Are we talking about for community-acquired pneumonia for otherwise healthy individuals? Then yes. So you can use azithro monotherapy as long as there isn't high rates of community resistance.
So Marianne.
Yes.
I think the question that Janaki and I were wondering was the first trial that you talked about with the CRP, how they were, we were wondering if, because it was just like antibiotic use after their CRP levels, and we were wondering if that was like cap therapy or if it was like inflammatory suppression with azithromycin.
Yeah, it was whatever the doctor wanted to give them. So I think it was primarily doxy or azithro, but they could give fluoroquinolone if they wanted to. So that was not one of the things that was controlled.
All right.
Let's see here. And is there a relationship between vitamin E and THC containing products? Asking for a friend there, Izzy. No, I just kidding. I don't know that. I think it was just that the liquid that that vitamin E has been an additive in vaping liquid, I think, to make it more, I don't know, vapable. But I don't know if it was, but that is also found in tobacco containing vape liquid. Oh, Alana also already answered you. Okay, so I'm gonna, I think now might be a good time for everyone to wiggle and stretch. I don't know if you need official breaks or you're just gonna go, you know, take care of your own needs at your own time, but we'll take a minute here to just switch over, and if anyone needs a stretch break or to get another cup of coffee, now is a good time to do that.
Great. So wiggle, wiggle, and then someone let me know if you can now see the case about Douaks and kidney disease.
Yes, we can, Anna, where you're seeing your screen.
Excellent. Okay, well, I'm just going to press on and we'll forge ahead, wiggle when you need to. So let's return to both Mr. Tation and Douaks, our favorite. Mr. Tation, this is great continuity. He's coming back to see us in primary care clinic 2 years later now. Reviewing his labs at this visit, his provider notes that his estimated GFR has dropped to about 28 over the last several lab checks. He continues to do pretty well. He's still on his Apixaban, his other routine medicines, not having any new bruising or bleeding. So the question we're going to be addressing next is what is the safety of continuing Douaks in patients who have stage 4 or 5 kidney disease? And just as a little background, this is an area where it turns out there's surprisingly little randomized trial data. So with that being said, I was excited to see this article published last August in the Annals, Benefits and Harms of Oral Anticoagulant Therapy in Chronic Kidney Disease. And the background here is that folks who have advanced kidney disease, stage 3, 4, and 5, are actually more likely to have the conditions for which we like to anticoagulate people, including atrial fibrillation and venous thromboembolism and thrombotic events and cardiovascular events. So there are people who were often in the scenario of wanting to give them an anticoagulant. That being said, they're also at higher risk to bleed and are more challenging to manage on warfarin and these other agents because of varying renal clearance issues and dialysis considerations and everything else. So this is a vulnerable group who is both at risk for these conditions and also bleeding. So it's been a little bit challenging to determine what's the balance of risks and benefits. So here we enter this review. So the authors here are asking, what are the benefits and harms of oral anticoagulant therapy for various clinical indications in patients who have stage 3 or greater kidney disease, including patients receiving dialysis? And of course, they designed this as systematic review and meta-analysis. I will mention here, very importantly, they did not include any observational trials. They only looked at randomized prospective trials. They ended up identifying 45 randomized trials, including about 34,000 adults who had stage 3 or greater kidney disease or were receiving dialysis. And the intervention in these trials was variable depending on what was the specific trial design, but what I'll be sharing with you is the results where they compared patients who were receiving a DOAC versus receiving warfarin for one of several indications that they looked at. And then just so for your knowledge though, the review also includes a lot of other intervention versus control arms. So it may have been, it was DOAC versus placebo or vitamin K versus placebo, DOAC versus aspirin, et cetera, just to let you know there's such a heterogeneity of sort of what do we do with these folks and what are the different things that have been tried. And then in terms of the outcomes, it really depended on the study. So 11 of these trials were looking at AFib, so preventing stroke or embolism. About 11 were also looking at preventing recurrent venous thromboembolic events, and then a hodgepodge were looking at other cardiovascular or thrombotic outcomes. All of them included a safety outcome as well. So what did they find? I think the punchline that I'll just steal my own thunder and tell you ahead of time is that we really can't take a lot away from this review and meta-analysis. But let's say what we can learn. So focusing on AFib, they identified 5 trials that compared full dose DOAC versus warfarin in patients with stage 3 or greater kidney disease that were looking at the outcome of preventing ischemic stroke. And one thing to note right off the bat is that, however, none of these trials actually included people with more advanced stage 4 or 5 kidney disease. So this is really a stage 3 kidney disease cohort when it comes down to it. However, for stage 3 kidney disease folks, it turned out that folks on DOAC did better than warfarin when it came to preventing a stroke with AFib. So that's a good, I think, finding and reassuring finding for us. They also had less deaths when they were getting DOAC compared to vitamin K. And not surprising, perhaps given some other data we have for these groups, they had less hemorrhagic stroke and intracranial hemorrhage. What was a little surprising to me is that when it came to the composite of all bleeding events that were major and non-major but relevant, there was really no difference here. And that finding of no significant difference here then becomes the punchline for the rest of the outcomes they looked at in this trial. So for all the other indications I told you about, preventing VTE recurrence, preventing thrombotic events, other cardiovascular events, dialysis, thrombosis, they really didn't find a difference in terms of the outcome when they compared DOAC versus vitamin K, nor did they find a difference in bleeding. I think the reasons for that are several, partly that there are just very few studies overall. The studies are small, they're really heterogeneous. But the other thing to be aware of is that none of these trials included people who had a GFR less than 25. So the other major punchline is that there's just not good randomized data. Now, all that being said, as you know from your clinical practice, and I know as well, we're using DOACs in these patients. They're FDA approved based on some extrapolation data, but they're actually being used. And that's essentially because of a lot of observational data and just practical experience. So I think this is an area where sort of the art of medicine reigns supreme. We're using these, we're learning from them as they go. It still is not a slam dunk decision to put a patient who's on dialysis on a blood thinner of any type, but it's a lot of risk benefit review and consultation with Anticoagulant clinic, their nephrologist, their hematologist, et cetera, depending on what the indication is and what their other comorbidities are, life expectancy, et cetera, these are kind of nuanced decisions. So the punchline here for me was I was hoping that this would be more useful than it is, but I think it's just useful to know what the state of the evidence is. And I'll also share the good news. There are lots of trials ongoing now that are trying to answer this question in a more robust or systematic way. So that's the DOAC kidney disease update. Moving on toward a different DOAC scenario. So here we're going to look at DOACs in patients who have malignancy-associated venous thromboembolism. So our delightful patient, Mr. Tation, sister calls him to share that she was recently diagnosed with a blood clot in her leg. She's 70, she was previously healthy, but now undergoing neoadjuvant chemotherapy for stage 3 breast cancer. She doesn't want to take warfarin. She's heard bad things about that. She's not a fan of needles, and she's wondering if she can use a medicine like Apixaban that he takes to treat her cancer-associated DVT. So let's look at this trial. This is also a systematic review and meta-analysis that was published in December in Mayo Clinical Proceedings. And the background here is that up until recently, low molecular weight heparins have really been the agent of choice or standard care to treat malignancy-associated VTE. And this came out of data that showed that low molecular weight heparin was clearly safer than warfarin in this population. So as you probably know and make sense, the malignancy-associated VTE folks are at particularly high risk for bleeding for many reasons related to their cancer. They may have cytopenias, they're undergoing frequent procedures, their treatments changing all the time, so they're kind of a vulnerable population when it comes to bleeding. And so having a more agile, shorter acting anticoagulant seemed to be quite a bit safer for them. Now enter the DOACs, and what's the role of DOACs in this population? So the authors here again are asking, what's the safety and efficacy of DOACs in the treatment of cancer-associated acute venous thrombosis? They identified 3 high-quality randomized trials that included a total of 7,800 patients who had cancer-associated VTE who were given one of the 3 Douaks you see here, either Edoxaban, Rivaroxaban, or Apixaban. Of note, the Edoxaban trial was by far the largest, then second largest was Rivaroxaban, and smallest was Apixaban. In all of them, the comparison was low molecular weight heparin, and they were treated for 6 to 12 months. And their primary outcome was risk of VTE recurrence, and they also had a safety bleeding outcome. So what did they find? So interestingly, when you look at the outcome of preventing a VTE recurrence, the Douaks won here. So forest plot clearly favoring DOAC as having less recurrent VTE events. However, and this surprised me a little bit, when it came to the bleeding outcome, actually the dalteparin folks, so the low molecular weight heparin folks, did better. They had less bleeding. The outlier here was this very small Apixaban trial, which you can see pointing to the dot there. Because it was small in numbers, the effect size wasn't enough to pull the whole group, but interesting data that is being followed up with a larger Apixaban study. So for now, kind of the conclusion is that yes, you'll have less recurrence of VTE, but at the cost of more bleeding. And so what it comes down to, and this is consistent with the updated American Society of Clinical Oncology guidelines, is that really you have, again, some art of medicine here. You can consider using either low molecular weight heparin or DOAC to treat malignancy-associated VTE, but you really need to consider your individual patient and their bleeding risk. Of note, certain cancer patients are more likely to bleed, particularly GI cancers. That's been seen fairly consistently. Also, think about your patient, what they have on the docket. If they're having a lot of procedures, surgeries, complications, cytopenias, they might be a better low molecular weight heparin candidate as compared to DOAC. So that's kind of the 2 trials to finish out our round 2 of the DOAC. So I am going to actually pause there and start studying the chat for questions, and then also turn it back over to Marianne.
Hi, thanks, Anna. Again, I don't see a lot of questions. I was just actually typing out a response to Alana's earlier question. I've been digging through the supplemental information from that CRP trial. Looks like the antibiotics that were used, mostly amoxicillin, then in order of use, doxycycline, clarithromycin, amoxiclav, erythromycin, and cephalexin. But mostly between amox and doxy, it was like plus 80, more than 80% of patients got those. Okay, let's see here if I can get back to Zoom without killing everybody. Does this look right to everybody from your screen? Oh wait, am I even sharing screen yet? No. Where are we?
We do not see your screen yet, Marianne.
Okay.
I'm just curious if people are seeing cancer-related VTE being treated with DOAC now, and if you are, I'd be curious to hear about that in the chat. I don't know that I've seen it yet in my panel, but I expect I will.
Are you seeing the actual presentation now, or are you seeing the presenter view?
This looks good to me.
Looks good.
I think
And go for it.
Yeah.
So, all right, cool. Thanks, everybody. Again, if you need to stand up or dance while we're talking, get some water, have a treat. We're going to talk about opioids and opioid use disorder. Some of these, again, are sort of trials that are interesting for a future state, and some of them are included because I like the people who wrote them and think it's sort of interesting to think about. Go dive right into the first case, maybe. Where are we? Okay. So Ms. Bierks is a 26-year-old woman. She's developed an opioid use disorder after receiving oxycodone for a lower back strain when she was 18. She had been buying illicit hydrocodone, oxycodone, fentanyl pills for 6 years before starting on Suboxone through her primary care provider 2 years ago. And she's doing really well, but she wonders if there's something longer acting she can try for her opioid use disorder, because remembering to take medicine is not her forte. And so thankfully there was a trial looking at the efficacy and safety of an extended release buprenorphine preparation. So this is called Bup XR, which is basically a monthly injectable buprenorphine. The study was done in 504 participants, sort of young adult to middle age with moderate or severe opioid use disorder based on DSM-5 criteria. They did a randomized double-blind placebo-controlled trial at 36 treatment centers in the United States, and the intervention, it was a 4-4-1-1 assignment. So basically people were put into groups of getting 6 monthly injections of 300 milligram bup XR, so that's the higher dose, and then another group with 2 monthly injections of the 300 milligrams followed by 4 of 100 milligrams, and then 2 placebo groups to match. And everybody also got individual counseling every week. So they're looking at both efficacy and safety, wanting to see what % of the groups were abstinent from opioid use, so negative urine drug screens and self-reports, and what were the safety profiles. The findings are listed here. First, achieving abstinence by week, so starting at the beginning, and this is by percentage of people achieving abstinence. So greater than 10% had abstinence of like 80-ish%. And then when you get to 100% abstinence, only about 15% achieved that. But 80% abstinence was considered a success. And 29% of the bup arms and 28%, 29% achieved abstinence 80% of the time, versus 2% of the placebo arm. And in terms of weeks abstinent, the bup arms were abstinent about 41 to 43% of the weeks versus just 5% of the weeks in the placebo arm. The trial had a high dropout rate, especially in the placebo arm, not surprising. 63% completed it in the bup arm and 34% in the placebo arm. The adverse events or side effects that are what people would expect, headache always listed, constipation higher in the bup arm, nausea higher in the bup arm, and injection site pruritus. But still kind of a compelling outcome. So what we know is that this was an industry-funded trial, so we always have to take everything they do with a grain of salt. There was a low treatment retention rate, not surprising, but not that different than buprenorphine treatment retention rates in general. So in this trial, we found that participants' percentage of abstinence from illicit opioids was much higher in both bup arms, and no different between the 2 bup arms, suggesting that a lower dose buprenorphine could be equally effective to the higher dose. And the treatment was generally well tolerated. So we should start thinking about, when this is ready for prime time, whether we want to consider this as an option for our opioid use disorder treatment. This would be potentially a big advancement in the treatment of opioid use disorder, could improve adherence, reduce any sort of wearing off effect, eliminates risk of diversion or accidental exposures. But another limitation is really that we haven't studied this against oral or sublingual buprenorphine or other treatments for opioid use disorders. So I think studying this extended release buprenorphine against other treatments rather than versus placebo would be an important thing to do before we start favoring it over other treatment options. Obviously, anything is better than placebo. So Ms. Bierk's cousin lives in a different state, and she's frustrated that she can't access treatment for her opioid use disorder. She wonders if there are any providers near her who could help her. So this is a study that came out of our local system here, looking at the distribution of X waivers for prescribing buprenorphine. You might recognize some of the names here. The first author, I think, was a medical student, potentially. Anyway, so the question is, how does the geographic distribution of waivered physicians and other providers at the end of 2017 differ from 5 years earlier? So they looked at all DEA waivered providers. and assigned them into different geographic designations: metropolitan, micropolitan, not adjacent to metropolitan, and then small and remote rural. They looked at counties without a waivered provider, and then the county provider to population ratio. And here is our beautiful map of the United States, blue being having a physician, a county with both a physician and an advanced practitioner waivered. Green is physician only, red is APP only, and white is no provider. So not surprisingly, our rural counties are really lacking in providers, if just looking at that picture at a glance. The good news is that availability of providers with DEA waivers has increased in all categories since 2012. So 56% of rural counties still lack a provider, but it was 67% in 2012. But almost 1/3 of rural Americans live in a county without a provider, compared with 2% of urban Americans. And NPs and PAs have added coverage in 56 counties since the passage of the Comprehensive Addiction and Recovery Act of 2016, which is great. NPs and PAs, you probably all know, have to go through 24 hours of training as opposed to the 8-ish hours that doctors have to go through, which is certainly a barrier for APPs who want to become buprenorphine prescribers. So overall, access to medication for opioid use disorder has improved, but lack of access still disproportionately impacts rural Americans. I know we're working on trying to get everybody waivered, and a lot of medical schools are as well, but this probably also maps pretty well with counties where there just aren't as many doctors and providers in general. This next study came out in the Journal of General Internal Medicine, trying to see if there's an association between the number of certified buprenorphine prescribers and the quantity of buprenorphine prescriptions, because obviously just because you have an X waiver doesn't mean you're using it. So they wanted to see, does it actually increase the number of people getting buprenorphine if you increase the number of providers. They did a retrospective observational study using DEA data. Interestingly, they used total amount of buprenorphine dispersed by zip codes. They look at the first 3 digits of the zip code as a sort of area of concern. And then the total count of providers certified to prescribe buprenorphine by zip code, also the first 3 digits. Obviously, there are limitations in this technique because the zip code of the provider and the zip code of the pharmacy where it's dispensed is not necessarily, or probably not usually, even the zip code where the patient is picking up or where the patient actually lives, but probably fairly close geographically. What they found was for those who have a cap of 30 patients, that is associated with an additional 3.6 patients getting buprenorphine per provider. A cap of 100 patients is an additional 8.7 patients per provider, and a cap of 275 patients is an additional 44 patients per provider. So it does, having more providers actually does increase the number of people getting prescriptions for buprenorphine. I mentioned some limitations. Obviously, this is observational data. You can't separate out buprenorphine for pain versus buprenorphine for addiction. That would bias it towards the null. And then the zip code of the prescription isn't necessarily the zip code of the patient. But this is a potentially positive, optimistic look at getting more providers. Getting more waivered providers actually increases access for our patients. And then finally, if you look at the list of authors on this group of people that I adore, but also it's a really interesting study. So Dr. James et al. Published this in JGIM this year, looking at mortality after discontinuation of primary care-based chronic opioid therapy for pain. So this is an area near and dear to my heart because the era of my training has gone from everybody gets all the pain meds they want to nobody gets any pain meds, and then sort of swinging back and forth. It's been a lot of whiplash for those of us in primary care. And so there's been a big move over the past half decade to decade to really wean people off of chronic opioids for pain. And so I think Dr. James and her team really smartly wanted to look at what are the associations between discontinuation of chronic opioid therapy and mortality, prescription opioid use, and primary care utilization. This is a retrospective cohort of 572 patients who are the people we take care of in this community, average middle age, those with chronic pain enrolled in the opioid registry as of May 2010. And the results showed that chronic opioid therapy was discontinued in 344 patients, so 60% of those patients at that cohort. Most had at least one provider-initiated reason for discontinuation, so diversion or other medications, other illicit drugs, or just other sort of behaviors that put them at high risk, or chronic medical conditions that put them at high risk for bad outcomes. Of those who had it discontinued, almost 3/4 actually got opioids from someone else. And over half continued to visit the clinic and see their primary care provider, which is great, but that means that 45% of them did not. 20% of the people, 21% of the people who had their chronic opioid therapy discontinued died. It's a high mortality rate. And of those, 3.7 died of a confirmed or possible overdose, and 4.9 discontinued patients died of overdose. Oh, sorry, let me rewind. 119 of the total cohort died, but the death rate among overall was 3.7 of confirmed or possible overdose, and it was 5% of the people who had their opioids discontinued died of an overdose. So what we learned from this study is that in this cohort, discontinuation of chronic opioid therapy was associated with an increased risk of overdose death. And I think, you know, there are obviously limitations. It's a single center, it's retrospective, but these are our patients. This is Harborview and this is Seattle. And this is something that we're all grappling with all the time. So whether or not to continue or discontinue chronic opioid therapy in people who are at high risk of harm with continuation, we need to also keep in mind that discontinuing the chronic opioids also puts people at high risk of harm with a pretty high mortality rate. And then finally, the Journal of Clinical Sleep Medicine came out with chronic opioid therapy and sleep recommendations. Nothing really earth-shattering here, but just something to keep in mind that chronic opioid therapy alters sleep architecture, causes respiratory depression, as we all know, and that's in a dose-dependent manner. So the higher the dose, the worse the respiratory depression. None of this is rocket science, but also leads to decreased sleep efficiency, reduction in REM sleep, and increased snoring. So we should be screening and testing our patients on chronic opioid therapy because we can identify sleep-related hypoventilation, central sleep apnea, obstructive sleep apnea, and that if we treat their sleep-related breathing disorder, we can improve their health and well-being. They also, in this update, cautiously and judiciously, with a lot of asterisks, recommend low-dose opioid therapy for treatment of severe refractory restless leg syndrome for people who are not responding to the dopamine agonists. So, quick take, if you have a patient on chronic opioid therapy, screen them for sleep disorders. Have a low threshold for an in-center sleep study. They're not eligible for home testing or should not get home testing, and then PAP therapy is going to be effective. So here's our opioid use disorder and opioids take-home points. Extended release buprenorphine is potentially going to be a safe and effective treatment for opioid use disorder, but I want to see a trial comparing it to oral. Access to bup is improving, but rural Americans are disproportionately impacted by lack of access. Discontinuation of chronic opioid therapy may put patients at increased risk of overdose death, and we should be screening all of our patients on chronic opioid therapy for sleep disorders and have a low threshold for diagnostic treatment or testing and PAP therapy. So those are the quick opioid use disorder and opioid updates. Does anybody have questions or anything in the chat that people want to talk about? James, yes, I agree. maybe unethical to do a placebo-controlled trial with Bup XR. And I need to go back and look and see, was that people who were not yet on treatment? But either way, we know that that the medication works for opioid use disorder. But you know, it's drug industry funded, so they want to show a good outcome. Sierra, that's a really good question. I think that data probably exists, but I don't have it at the tip of my fingers. Does anybody know that information? I can look it up while Anna's talking.
We need Jocelyn, Joe, or Jared on the call.
Yeah, right.
As the
Phone
experts.
a friend. Phone a friend. I will
Yes.
look that up because I think that is a point well taken, Sierra. We need to think also about the rate of overdose death and people continued on chronic opioids for pain.
Mhm.
I don't think it's 5%, but I think it's not insignificant, obviously, or else we wouldn't be even having these conversations.
Mhm. I'll just share that I just got my X waiver myself, which I'm later than all of you, but I'm proud of that accomplishment.
Good for you, Anna.
Thank you. Thank you. Late to the game, as usual, but excited.
Cool. All right, I'm gonna stop sharing and pass it back to the lovely Dr. G here.
Okay, so let me know. Whoops. Let's see, let's get it to present or slideshow. Okay, is everyone seeing the case regarding diabetes on their screen? Marianne or
Yes.
Sarah can, yes, okay, great. So again, move if you need to, and as you need to, throw questions in the chat. For those who know me, they know I like to talk about diabetes and learn and teach about diabetes. So I'm excited for this section. So lots of enthusiasm on my part. So let's talk about a new patient now. This is Miss Suga. She's a 62-year-old woman with type 2 diabetes, stage 3 kidney disease, coronary disease, and hypertension coming in for follow-up. She's currently taking max dose metformin, max dose lisinopril, and high dose atorvastatin. And her labs done before today's visit show her A1C is now 8.1, her estimated GFR is 55, and her albumin to creatinine ratio is 100. So the question that we are posing is, what is the next most appropriate agent to add to her diabetes regimen to improve her cardiovascular and CKD outcomes? And while now this feels, I don't know, a little bit old, I think it's hard to overestimate the importance of this, because before this data came out, we really didn't have a good answer for her. We would just tell her, you know, you're maxed out on your lisinopril. We just need to keep working on better glycemic control and better blood pressure control, and that's what we can do. But now enter the Credence Trial. So the Credence Trial was published in the New England Journal back in June, a year ago, so almost a year ago. And this trial was the first prospectively designed trial to look at renal outcomes specifically with the SGLT2 inhibitors. The background here is that there was some positive signal coming out of secondary endpoints of the big SGLT2 trials looking at cardiovascular outcomes. So this is IMPA-REG and CANVAS, looking at some of these secondary renal outcomes that were showing, maybe these agents were also causing renal benefits in addition to the cardiac benefits that were found in those big trials. So this was, again, the first prospective renal outcome designed trial. They are asking here, what is the effect of canagliflozin in adults with type 2 diabetes and albuminuric CKD? The population here included 4,400 adults who had type 2 diabetes, a really generous A1C range here, ranging from 6.5 to 12, and GFR 30 to 90. So this is a stage 2 and 3 kidney disease cohort. They also all had to have urine albumin to creatinine ratio at least 300, so it's more of a macroalbuminuric population. They already had to be receiving max tolerated ACE or ARB. And I'll also share that they really wanted this to be a diabetes kidney disease cohort, so they did try to exclude people who had kidney disease from other causes besides diabetes, so no autoimmune or inflammatory kidney disease patients. Also, I'll share that midway through their enrollment, based on Canvas data showing a small but significant excess in distal amputation, they changed the exclusion criteria for this trial such that they excluded patients perceived at high risk for amputation. The intervention folks received canagliflozin 100 milligrams daily versus placebo, and the outcomes that they looked at, the primary was a composite of serious renal outcomes, and they also had a composite of renal and cardiac outcomes. They had a ton of different pre-specified secondary outcomes, which are listed here, and of course they were looking at safety outcomes as well. So what did they find? I first want to draw your attention to the renal specific composite outcome because it's very interesting. So again, what that composed of was people who had a doubling of serum creatinine, dropping their GFR less than 15, needing to initiate renal replacement therapy during the trial, or renal death. So all very serious renal complications. And for this composite outcome, the folks getting canagliflozin had a hazard ratio of 0.66. So a very impressive reduction in that composite outcome, correlating to a number needed to treat of 22 patients for 2.5 years to achieve that outcome. Similarly, when they looked at their cardiovascular and renal combined outcome, they had a benefit with the SGLT2 arm, and this held true for each of the individual components of those composites. And when it came to any of the adverse events, they did not, specifically amputations, they did not find that. But again, remember that they changed their exclusion criteria partway through, trying to exclude people who would be at high risk for amputation. So I also just want to share that the benefit seemed to hold regardless of what stage of kidney disease in their included patients you're looking at. So whether their GFR was around 30 in the sort of stage 3B range versus the stage 2 folks, benefit held. That's also true regardless of how much albuminuria the patients had. They sort of looked at an arbitrary cutoff of less than or greater than 1,000 for urine albumin to creatinine ratio, and the benefit held. So positive signal there. I'll also just share, in case you don't know, that when you start an SGLT2, you are going to see an initial mild drop in GFR that has to do with the mechanism. So remember that they cause afferent arterial or vasoconstriction, similar to ACE-ARB mechanisms. So you see a little drop in GFR that is reversible when you stop medication, but then remains stable, whereas folks not getting SGLT2 have a more steady decline in GFR throughout the duration of the time they're on medication. So very exciting information about the effect of this med class on kidney disease, and resulting in recommendation that this be started as early as possible for patients who are at risk for progression of diabetes-related kidney disease. However, you can't talk about SGLT2s with patients without reviewing some of the serious adverse outcomes that have been associated with this drug class. And I wanted to bring attention to this case series, which was published in May in the Annals. And this is looking at Fournier gangrene associated with SGLT2 inhibitors. So the authors here were able to identify 55 unique cases of Fournier gangrene that had been reported since SGLT2s were marketed starting in March of 2013, going through January of 2019. And to compare, they looked at sort of what are the cases of Fournier gangrene associated with other diabetes med classes. And going back to 1984, there were only 19. So this does appear to be an increased risk with this medication class, but to give it perspective, it's really, really rare. So for context, the FDA estimated that just in 2017 alone, there were 1.7 million patients prescribed an SGLT2 inhibitor. So you can see by the math, the Fournier gangrene is exceedingly rare, but very scary. And so when I talk to patients about this, I just say, this is something that's so, so rare, but I will think about them as an individual. If I think they're high risk for sort of severe genitourinary or anorectal infections, I may give pause before I would order this medication. Or if I think there's someone who couldn't monitor their skin or seek help in an appropriate time frame, it may give me pause, and I'll counsel them on what to look for and that they should stop the medicine if they see anything of concern. And this is also a time when I like to just take a pause and talk about some of the other side effects with this med class that are important for us to be able to counsel patients on. So starting with the other serious but also exceedingly rare, the distal amputation does also catch people's attention. It makes them nervous. And just for your reference, that was 3 excess amputations per 1,000 patient years seen in the Canvas trial, which has been similarly replicated in other review of post-market evaluations of these agents. And again, the bottom line is, yes, it's probably statistically significant, but it's so rare. That being said, again, should give you pause if your patient is sitting in front of you is at higher risk for an amputation, has had an amputation, has severe neuropathy, has diabetic foot ulcers. That's not the right person to start this med for, but otherwise just counsel people, let them know this is out there. They should be watching their feet and seeking care if they have any foot wounds or non-healing lesions. Now let's turn to the more common things that actually will happen to a large number of patients on these medications. And the first one is that they really do drop blood pressure. So when I start an SGLT2, I will empirically reduce the patient's other blood pressure lowering agents, and I'll counsel people to look out for lightheadedness and increase their oral liquid intake. Secondly, vulvovaginal candidiasis is happening about 2 to 4-fold higher than usual on these medications. And so if your patient, especially women, have this happen, you should stop the med, treat them, and then do risk-benefit sort of shared decision-making to decide whether to restart. And lastly, UTI, there is a little bit, sort of a 2% reported increase in rate of UTI. Again, if your patient has urinary retention, if they have an indwelling Foley, that may be someone who you should consider avoiding this med class. So that's kind of the roundup regarding side effects of SGLT2s and how I counsel patients. So let's talk about another SGLT2 article that came out this year. And just going back to the case, our patient, Miss Juga, she tells us that her cousin was recently diagnosed with heart failure, and he has a whole slew of new medications, including empagliflozin. And that confuses her a bit because she said, you know, he doesn't even have diabetes, so why is he on the same diabetes medicine that I'm on? So here we're going to look at the evidence to support the use of SGLT2 inhibitors in patients who have heart failure. So enter the DAPA-HF trial published in November of 2019, also in the New England Journal. And again, the background here, this makes sense this trial was done because of the very positive signal seen in all of those cardiovascular safety trials in diabetic patients that SGLT2s significantly reduced admissions for heart failure. And so, of course, the makers of these agents wanted to capitalize on that finding and, of course, help our patients, I'm sure, by looking at this other population. So the authors here are asking, what is the efficacy and safety of dapagliflozin in patients who have heart failure with reduced EF, whether or not they have diabetes? This was designed as a phase 3 randomized, blinded, placebo-controlled trial, included 4,700 adults who had New York Heart Association heart failure, at least class 2 or graded or greater. Their EF all had to be less than 40%, and they were trying to capture a more active heart failure population, so they also stipulated that they needed to have either an elevated BNP or have had an admission for heart failure within the past year. The intervention arm received dapagliflozin, and the control arm got placebo, and the outcome they were looking at primarily was a composite of either worsening heart failure, meaning they needed to come in for an urgent IV diuresis or to be admitted, or that they had death. And they had a bunch of secondary safety outcomes as well. So what did they find when it came to their primary outcome? Again, composite of needing IV diuresis or admission or having death. The people getting SGLT2 clearly did better, hazard ratio of 0.74 that was significant, with a number needed to treat of just 21 over a couple of years to prevent one of those outcomes. When it came to safety, they did very well. So the folks on SGLT2 arm actually didn't have any of the concerning side effects or adverse effects that we talked about with this med class. I will share that they did exclude people who had borderline low blood pressure at the start, and that I think they were trying to avoid this issue of causing hypotension or volume depletion. So some positive signal regarding, and oh, sorry, I should also share that this benefit was seen whether or not the patients had diabetes at baseline. So 40% of these folks did and 60% did not, and the effects were the same regardless of presence of diabetes. So this is really thought to be a mechanism apart from glycemic lowering, which is also the case in people with diabetes regarding the other benefits that we're seeing, such as the renal outcomes. Okay. So let's turn back to our patient, Ms. Suga. She's doing well with the addition of empagliflozin to her diabetes regimen, but she's really frustrated about her weight, and she wants to know what other options are available to help her lose some weight. The caveat is that she, like our other patient, really is not excited about needles and has not been willing to consider a GLP-1 in the past because of the injection issue. So now we turn to what can we offer her in today's regimen or armamentarium for treating diabetes. So I'm going to talk about the Pioneer 4 trial, which was published in the Lancet in July. And this was the big trial that introduced the first oral GLP-1 receptor agonist. As you probably know, the issue with the GLP-1s is that they are peptides that are very challenging to be absorbed across the gastric mucosa. They have very poor oral bioavailability, hence them all being injectable. But the clever makers of this agent, who pay me no money, figured out how to co-formulate it with another chemical that enhanced absorption across the gastric mucosa. So they wanted to test it and see how it performed as compared to a subcutaneously administered GLP-1, and that's the basis for this trial. This was designed as a randomized, double-blind, double-dummy, active and placebo-controlled phase 3A trial, super fancy, including 771 adults who all had type 2 diabetes, a more moderate range A1C 7 to 9.5, and they all were already receiving metformin, and they could be receiving an SGLT2 inhibitor. The intervention folks got oral semaglutide, and they tried to titrate the dose up to a full dose, which was 14 milligrams per day. I'll also share, it's pretty important and nuanced how you should take oral semaglutide. So in order to enhance the absorption, the directions are to take it by itself with only a half glass of water on an otherwise empty stomach with no other pills, medicines, food, or liquid, and then wait for at least a half an hour or more before eating anything else. So kind of like a levothyroxine dosing regimen. And then again, the controls were injectable GLP-1, in this case liraglutide, which is a daily injection, and also a placebo. And the outcomes they were looking at primarily was change in A1C from baseline to week 26, and also they followed folks out to 52 weeks, and also what was the change in weight. So what did they find? I think it's maybe a little bit easier even to see on the graph here below. So blue is oral semaglutide, pink is injectable liraglutide, and then green is placebo. And as you can see, the oral semaglutide had a very similar A1C lowering at the halfway mark compared to injectable liraglutide. At the 52-week mark, it actually was slightly, significantly better in A1C lowering, so that's great, interesting. And then when it came to weight, you can see that oral semaglutide was the winner here. So drop in 4.4 kilograms, which actually was sustained throughout the duration of the trial, which is great, which actually was also significantly better than the injectable liraglutide and much better than placebo. So the conclusion here by the authors is that oral semaglutide really held up quite well, and maybe even a little bit better as compared to an injected GLP-1 receptor agonist. Very exciting. Okay, and then I just want to spend a brief moment on Pioneer 6, which was the requisite cardiovascular safety trial done to look at this agent as is required for all newer diabetes agents. So this was designed very similarly to all the other trials you're familiar with, including LEADER, etc. And basically, I'll kind of skip to what they found. So they're looking at MACE here. Good news, it appeared that the oral semaglutide was safe, so there was no excess of cardiovascular adverse events. They weren't actually able to show superiority, as you recall with leader and dulaglutide and injectable semaglutide. They all had superiority, but here it's just a non-inferiority because the benefit wasn't quite statistically significant. But in any case, we can feel confident that oral semaglutide is certainly non-inferior or safe when it comes to cardiovascular outcomes. All right, so to round up our diabetes bundle here, very exciting, SGLT2, specifically canagliflozin, was found to improve renal outcomes in patients who had diabetic-related kidney disease. There are some exceedingly rare but important to know about adverse events with SGLT2s, including Fournier gangrene. We talked about how to counsel patients about that. Dapagliflozin reduced heart failure admissions for patients with HFrEF. And that was exciting, and that held up whether or not they had diabetes. And then turning to GLP-1s, oral semaglutide looked just as good, if not better, than injectable liraglutide for A1C lowering and weight loss. It was FDA approved as of September. And by the way, I've just seen a VA national formulary that includes it. So I am beyond excited about that exciting news in my VA world. And it seems to be safe for our patients. So I'm going to pause there for our diabetes bundle, and I'll definitely address questions as I see them.
Anna, the one question was about in the dapagliflozin study, I believe, was there a way to, were the patients otherwise on goal-directed medical therapy?
Yes, they absolutely had to be, and that included everything up into cardiac resynchronization, defibrillate, whatever was otherwise recommended. The patients were also getting Entresto. They were supposed to be getting spironolactone, so absolutely. And I actually tried to look and see how diuretic use differed based on whether or not they were in the SGLT2 arm, and I did not see that reported out in the trial results. I'm sure it's in some supplementary table that I couldn't get to, but I was curious about that because a lot of people said, is this just a diuretic effect alone? But they all were, you know, if they needed them, were given diuretics as needed. So it is really thought that similar to statins, there's some magic jujubes with these SGLT2s that's doing more beyond just volume and electrolyte management. We learn as we go.
Cool, thank you, Anna.
Sorry, Cody just had a quick question that I can take a second to. So Cody, I think this really has to do with the cohort that's included. So when in all these other trials, when they include a more severe cardiovascular disease cohort, they actually see more benefit. But to be more expedient in enrolling, they'll maybe include people that are just at risk for cardiovascular disease. And that's the case for this trial. I think they kind of took the shortcut and didn't just include people with known true blue disease, and because the population they included was a little bit less sick, they saw a little bit less benefit. So I actually think the cohort mattered a lot here. So I'm actually fairly reassured that there is cardiovascular benefit with the oral semaglutide as well. So anyway, I'll hand it over.
Cool. Are people seeing the right screen, Anna?
I see infectious diseases.
Okay,
Hooray.
and it does not look like the presenter screen. Okay, cool. Again, if people need to get up and wiggle, please do. You can be doing a workout while you listen to this, actually. I would never know. We're going to talk about infectious diseases, and I want to put a caveat on all of this, and this presentation was originally made for sort of a general medical audience, people who maybe been out of training for a long time and aren't necessarily keeping up with the literature. So I apologize. Some of this in this section probably is not going to be immediately educational for you in a way that it would be for someone who's been out of residency for 10 or 20 years. So bear with me. I'll try not to take too much of your time. We're going to start with maybe Luis Garganta. He's a 31-year-old man. He's new to your clinic. He's in relatively good health. He had ear infections and tonsillitis as a kid, had a tonsillectomy and adenoidectomy at the age of 14. And as he's leaving, even though you did amazing agenda setting, just like you were trained to do, he says, "Hey doc, my old doctor gave me a Z-Pak and a prescription for Augmentin just in case. Can I get those refilled today?" What do? Do you A, notice that you're 20 minutes late in your day and decide to give him the antibiotics? Do you B, smile and have a conversation? So this makes you wonder, how often are antibiotics prescribed without a documented indication? There's an interesting article that came out this year, identifying the problem that 60% of antibiotic costs and 90% of antibiotic use originates from ambulatory care settings. And so these researchers wanted to know, how frequently are antibiotics prescribed in the absence of a documented indication in the ambulatory setting? What is the potential effect of an assessment of appropriateness of antibiotics? And what are the patient, provider, and visit level characteristics associated with antibiotic prescribing without a documented indication? This was a cross-sectional study using fancy statistics. They basically looked at basically a billion ambulatory care visits nationwide. I think this is Medicare, Medicaid kind of information, and also insurance, private insurance information. And they took about 30,000 sample visits representative of those almost billion ambulatory care visits. Looking at overall antibiotic prescribing, and then whether the antibiotic prescription was accompanied by appropriate, inappropriate, or no documented indication. What do you all think they're going to find? How are we doing? What they found is that antibiotics are prescribed during 13% of ambulatory care visits. This was in 2015. 57% of those were for appropriate indications, and 25% were inappropriate, and 18% had no documented indication. So inappropriate would be for like a, viral URI. 18% would be like maybe they had something, maybe they didn't, but the doctor didn't write it in their H&P, or didn't code for it, excuse me. It was all based on coding. Factors associated with antibiotics without an indication. Actually, if an adult man is more likely to get antibiotics without indication. Having at least one chronic disease, longer visits, so these visits that were coded for longer duration, and then seeing a non-primary care specialist. So in primary care, 12% of those antibiotic prescriptions were either inappropriate or undocumented. Ambulatory specialists who commonly prescribe antibiotics, that was 24% either inappropriate or undocumented, and then all other specialists, 29% inappropriate or undocumented. And sulfas and the urinary anti-infectives were most likely to be prescribed without documentation. I think this is not surprising for a number of reasons that we can talk about if you would like. Looking at the appropriateness of prescribing by class of antibiotic, penicillins have the highest rate, although not statistically different. The sulfas is the one that has a big difference, where it's the highest rate of inappropriate prescribing. So the conclusion of this is that 24 million antibiotics were prescribed in the United States without a documented indication. That is 43% of all antibiotics prescribed. And there are limitations to this study. They were only able to look at the first 5 ICD codes indicated in the data they had. So if somebody came in with 9 problems and a UTI was number 9, the researchers would not be able to capture that data. It doesn't capture prescribing from non-face-to-face visits. So for someone who has recurrent UTIs, who calls in with typical symptoms and gets an antibiotic prescription, that would count as a undocumented indication. It doesn't capture data from retail health clinics. So if someone's going to, Walgreens clinic and gets diagnosed with community-acquired pneumonia and gets a Z-Pak, that prescription would get counted, but the indication would not. And then the way that it's designed, because they're just looking at ICD-5 codes, they can't capture data from the HPI. So HPIs, as you know, might actually explain rationale for prescribing that don't end up getting coded for. So we don't actually truly know, is this a billing coding documentation problem or an antibiotic stewardship problem, or both? I would say probably both. I do think we obviously overprescribe antibiotics, but probably not always explaining our clinical reasoning very well in our documentation. So this next study came out of Emory, looking at the appropriateness of fluoroquinolone prescribing in both academic and non-academic primary care clinics. So they included in this study anyone who's received an outpatient prescription of oral Cipro or levofloxacin, and excluded Vulnerable populations with history of multiple infections, anyone with more than 2 antibiotic allergies, people with history of adverse drug reactions related to fluoroquinolones, or indications without institutional or national guidelines. They collected patient demographics, prescription information, why the prescription was written, microbiology data if they have it, return visit within 30 days for ADRs, provider status, and clinic site. So it's a retrospective study of 9 primary clinics within Grady Health, which is at Emory. So 4 were academic and 5 were non-academic primary care clinics. And they were interested in what percent of the time are fluoroquinolone prescriptions inappropriate, and is there a difference between clinicians and clinics, and the number of return visits for adverse drug reactions. What do you all think? Who's doing best here? Is it academic, non-academic? Is it attending? Is it resident? I think you all probably know that residents do everything the best, which this study confirmed. So fluoroquinolones were prescribed more frequently at non-academic clinics than academic clinics. So almost 75% of the time versus 26% of the time. Average duration of therapy was 7.1 days. Most common indication was urinary infections, which was almost 75% of all the prescriptions. And 90% of the fluoroquinolone prescriptions were determined inappropriate. 95% of the fluoroquinolone prescriptions at the non-academic clinics were inappropriate, compared with 73 at the academic clinics. And resident physicians are actually doing the best, such as it is, in prescribing fewer inappropriate fluoroquinolone prescriptions than attending physicians. So 79% of residents are inappropriate versus 92% of attending physicians and 91% of APPs. So in conclusion, there was higher inappropriate fluoroquinolone use in off-site non-academic clinics compared to academic. However, everybody was doing kind of egregiously poorly in this regard. This is primarily driven by inappropriate indication. So using fluoroquinolones for for basic urinary tract infections. Everyone's getting this prescription for Cipro apparently. Excessive duration, so getting treated for a very long time, or inappropriate dose. And the difference between academic and non-academic clinic sites, they surmised, could be associated with less visibility of hospital-driven, kind of system-driven antibiotic stewardship programs, and also in sites where there are trainees. The trainees are doing better, and that probably bleeds to the attendings to some extent as well. Limitations, this is a single center site in Atlanta. It might not reflect practices outside of that region, but certainly something to keep in mind as we're prescribing medication for urinary tract infections, COPD exacerbations, that we don't reach for fluoroquinolones unless we absolutely need them. And an oldie but a goodie, this is not from this year, but I love this study because I think about it on a very regular basis. This was looking at time of day and decision to prescribe antibiotics. And this, like always, is sort of my, this can be my moral compass at 4 p.m. on a Friday. But this was a group, I think, out of Boston looking at antibiotic prescribing by hour of the day in clinic, comparing like the first hour of your clinic session to the last hour of your clinic session. The odds ratio of antibiotic prescribing in the second, third, and fourth hours were basically no difference in the second hour, no significant, maybe a slightly significant difference in the third hour, but a real significant difference in the final hour of clinic. So odds ratio going up to 1.26, and this is significant for the linear trend. So I think this for me is always something that I reflect back on when I have a patient who I'm seeing at the end of the day when I'm running late and they want an antibiotic, and the little devil on my shoulder says, I could give them an antibiotic and make my day go away, or I could actually have a conversation with them about how this isn't appropriate. I try to reflect back on, like, what would I do if this were my first appointment of the day? I would not be giving this person antibiotics, and I shouldn't do it now. So just food for thought for all of us who struggle with trying to meet our patients' needs, trying to stay on time, trying to get home and have dinner with our families. So Mr. Garganta comes back. You, of course, did not give him a prescription for a Z-Pak and some amoxicillin just because he wanted it, but he does have a sore throat. He says it feels like he's swallowing broken glass. He has no cough or rhinorrhea or chest pain. His temp is 38.7. He has tender swollen cervical lymph nodes. And you send a rapid strep test and send him home with a prescription for antibiotics because you know your Centaur criteria and figure this guy has strep throat. How long should you treat him? Stop and think to yourself. Would you treat him for 3 days, 5 days, 7 days, 10 days? Would you not have treated him? A group in Sweden studied penicillin for 5 days versus penicillin for 10 days of patients with pharyngotonsillitis caused by group A strep. And they wanted to know, can we reduce the total exposure to penicillin while also maintaining adequate clinical efficacy? So it was an open label RCT. They had about 430 patients, half in a 5-day and half allocated to a 10-day regimen of penicillin. They included anyone ages 6 and over, so this does include some kids. And they had to have at least 3 or 4 Centaur criteria and group A strep, basically. They looked at this in 17 primary healthcare centers in Sweden. And again, we're giving them either penicillin 800 milligrams 4 times a day or for 5 days, or 1,000 3 times a day for 10 days. So a total of 30 grams versus 16 grams of penicillin. The primary outcome they were looking at was clinical cure at 5 to 7 days after the end of antibiotic treatment. And then the secondary outcome was bacteriological eradication, time to relief of symptoms, frequency of relapses, complications, and adverse events. And what we found is that there was no difference in clinical cure between the two groups, no statistically significant difference. There was slightly worse bacteriologic eradication. There was no difference in the 5-day group versus the 10-day group. There was no difference in average time to relief. There was no difference in relapse. There was no significant difference in complications. And actually the 10-day group had a higher rate of new tonsillitis than the 5-day group. So this is our time to first day of relief. As you can see, day 4 is where we hit the 50% mark for both groups. So in conclusion, this group found that penicillin 4 times daily for 5 days was non-inferior in clinical outcomes to penicillin 3 times daily for 10 days. The number of relapses and complications did not differ. And so 5-day treatment might be an alternative to 10 days, but it was only in Sweden. So don't know if that's generalizable. And also this lower bacteriological eradication rate, is this clinically relevant? Are we worried about the complications of incompletely eradicated strep in our patients? So I think that's something to keep in mind, that you're going to have a higher eradication rate if you treat them for longer. They're not going to feel any better, assuming they don't have any complications, post-strep complications. All right. So Ms. Jones is a 57-year-old woman who underwent a right total knee arthroplasty. She subsequently developed a prosthetic joint infection, and after a surgical washout, she strongly requests, I just want to get out of the hospital. I can't stand it anymore. Can I get an oral antibiotic? So you wonder, is it safe to treat Ms. Jones with an oral antibiotic for her prosthetic joint infection? The OVIVA trial came out this year. Many of you have probably already heard about it, but comparing oral antibiotics to parenteral antibiotics for bone and joint infections. It was a randomized open label non-inferiority trial. The population was mostly men, average age of 60, 80% of the infections were in the lower limb, but they did include spinal infections, including epidural spinal infections. And people got the first a bleed-in of IV antibiotics and then were randomized to either IV or oral antibiotics to complete 6 weeks of therapy. And the primary endpoint was definitive treatment failure. The current IDSA guidelines are for 6 weeks of IV antibiotics. or a highly bioavailable oral antimicrobial therapy. For vertebral osteomyelitis and for prosthetic joint infections, it's 2 to 6 weeks of IV antibiotics plus rifampin for staph, followed by rifampin and oral antibiotics for 3 months in the total joint infection, except for 6 months in a TKA. And other organisms other than staph, 4 to 6 weeks of IV antibiotics or a highly bioavailable oral antimicrobial therapy. The punchline here is that oral antibiotics were non-inferior to IV antibiotics for bone and joint infections when used during the first 6 weeks for these complex orthopedic infections. As you can see, oral better versus intravenous better. They did different analyses. So they did intention to treat, a modified intention to treat per protocol, and then worst case scenario kind of analysis. And even the worst case scenario showed non-inferiority. So overall, they had data for 96% of the participants, and treatment failure occurred in 14% in the IV group and 13% in the oral group. So there was no difference. Good news. And then we have Mr. Freudig. He's a 32-year-old man. He's presenting to establish care. He's generally quite healthy. He shares that he's sexually active with multiple male partners and inconsistently uses condoms. You screen him for HIV and other STIs, and his results are negative. In addition to counseling on safer sex practices, what can you offer to reduce Mr. Freudig's risk of acquiring HIV? I think this, in this audience today, I don't think this is going to be a surprise for anything, but PrEP is fully within the wheelhouse of primary care, and I want to encourage everybody who hasn't started offering PrEP to do so. It's super easy and really satisfying. So USPSTF actually came out with a recommendation this year that we should be offering PrEP to people at high risk of HIV acquisition. Those are men who have sex with men who are sexually active and have serodiscordant partners or inconsistent condom use or an STI within the past 6 months. Heterosexually active women and men who have serodiscordant partner, sorry, I should say people of all genders. So people of all genders who have a serodiscordant partner, inconsistent condom use with partners whose HIV status is unknown, and an STI within the last 6 months. And this is any of these, not all of these. Persons who inject drugs who share the use of their drug injection equipment or are at risk of sexual HIV acquisition, or persons who engage in transactional sex. And the recommendation is once daily treatment with a tenofovir M-tricytidine preparation. So preparing to prep to PrEP, obviously you want to take a detailed sexual history. And this is important because we need to know which mucous membranes to be screening. Screen for HIV, screen for STIs and infectious diseases at that initial visit, including syphilis, Hep B, Hep C, PCR for chlamydia, gonorrhea at all relevant mucosal sites, and then assess renal function, consider risks for osteoporosis, and if they're female, obviously we want to do a pregnancy test every time we see them. The choice of medications, it used to be we just did Truvada and didn't think about it, but Descovy came out and basically gave us a tenofovir preparation that doesn't cause the renal and bone toxicity. Descovy was pretty smart in that they knew that Truvada was going to be generic pretty soon, so they priced the Descovy at just slightly below the price of Truvada so that more people there wouldn't be a financial hit for people who wanted to change. So and they've also had a really big marketing campaign. But the thing that we want to talk to our patients about is that Descovy actually is going to cause more weight gain and dyslipidemia, so more sort of metabolic syndrome stuff versus the renal and bone toxicity. So some people actually get switched to Descovy, gain weight, and hate it. So important to think about what our patients are going to be willing to adhere to. So every visit, you want to assess and support their adherence. At the 1 month mark, you can assess for side effects. At the 3 month mark, you rescreen for HIV, STIs, check your renal function, assess for pregnancy. And every 3 months thereafter, you want to do HIV and STI screening and pregnancy testing, and every 6 months renal function. So it's not, certainly not more complicated than managing diabetes, and potentially extremely life-saving. So our quick takes on infectious disease. A significant minority of antibiotics prescribed in the ambulatory setting are either appropriate or lack appropriate documentation. Penicillin 4 times daily for 5 days was non-inferior in clinical outcomes to penicillin 3 times daily for 10 days in patients with group A strep pharyngitis. Oral antibiotic therapy is non-inferior to IV antibiotic therapy when used during the first 6 weeks for complex orthopedic infections. And then we should all be offering and prescribing PrEP to our patients at risk of acquiring HIV. So, what questions do you all have? Brian, that is such a good question. I don't know. I am woefully inadequately informed about insurance issues being at the VA, where I just get told by my pharmacy managers what I can prescribe and what I can't prescribe. Does anybody who's prescribing PrEP know if there's issues about prescribing outside of MSM and Descovy? James, I think that's really a good point. I actually have not, as a practice, been offering PrEP to people who are injecting drugs. And when I read the USPSTF update, it was kind of a big duh for me that it should potentially work. I think, however, the PrEP is working. I mean, sort of thinking about how it's working, it's getting into the mucous membranes and into the tissue. But I think it would make sense that we should be offering it to people who are injecting drugs. I should ask Anders. Anders is my local HIV and PrEP expert, but I think, I don't know, Alice, if you're on here, other folks who are prescribing more than others. It seems like a great opportunity when we're admitting people. We can put them on oral antibiotics for their bone infections and offer them PrEP. So I think the inpatient setting, when people are being admitted from complications from injection drug use, that'd be a great time to talk to them about PrEP. I wonder if here, because less of the HIV is transmitted via IV drugs, just because of the, although it certainly happens, it's more often sexually transmitted. I think we probably isn't on our minds as much. But a great conversation starter, James. I really appreciate that. So I am going to turn it over to the amazing Dr. G again. And while she gets started, everyone should, if you haven't done some calf raises and some squats and some lunges, maybe do a plank or two, wall sit, get your blood pumping.
Okay, let's see. We should be seeing the slide that says quick takes. So someone let me know if they're seeing that.
It's good, Anna.
All right, and good news for everyone. These are our last 3 articles of this entire session. It's been a marathon, but hopefully you picked up a few pearls, and we'll try to finish with a few interesting articles that caught my eye this year. So let's dive right into iron deficiency. So this is really a follow-up to something that caught our attention 2 years ago when we did this updates at ACP at that time, which is a really kind of small but elegant proof of concept study done by a group in Switzerland looking at best practices for giving iron supplementation. And what we found in that small study is that it turns out less is more when it comes to iron supplementation. What they found is that when you gave iron once per day as compared to multiple times per day, and also when you gave oral iron once every other day, instead of daily, you actually had better iron absorption into red blood cells. And the physiology behind that is because a dose of oral iron actually increases hepatic production of hepcidin, and then hepcidin causes a sort of block or a decreased absorption of oral iron for the next 24 hours. So you're sort of shooting yourself in the foot by giving iron too often, basically decreasing the ability to absorb that iron orally. So that study done a couple of years ago, I think, changed a lot of our practices in that we started spacing out iron dosing for patients. And this study, where it comes in, is that this study done by the same group in a similar design actually looks at iron supplementation in patients who had anemia. So the first cohort was just iron deficient women without anemia. Now they've become anemic. The reason they thought this might matter is because anemia is thought to suppress that whole hepcidin system such that it wouldn't be potentially play as big of a role, and they wanted to see if that was actually true. So here again, this is a very small study, really proof of concept physiology based, including 19 women who had iron deficiency anemia. They were college students in Switzerland. Their mean hemoglobin was 11.5 and mean ferritin was 10. The design is that it's a crossover trial, so all patients will receive both treatments, and they are treated either with 100 or 200 milligrams of labeled iron that's given on either consecutive days or every other day for the first cycle, and then they get the opposite regimen for the second cycle. The cycles are each 6 days in length, and they're separated by 16 days. And their outcomes that they looked at primarily was what was the absorption of labeled iron into the red blood cells. They also measured serum hepcidin levels and ferritin levels to make sure that the physiology still made sense and to track those. And what did they find? So similarly to that prior study, they found that iron absorption was 40 to 50% higher when given on alternate days, so when there'd been a skip day in between, compared to the consecutive day regimen. Similarly, serum hepcidin levels were also higher with the consecutive day doses, so really suggesting that that process is still going on even in the presence of anemia. They also found that the best iron absorption was when you gave a high dose supplement once a day on alternate days, and that actually doubled how much iron was absorbed compared to giving the lower dose supplement on consecutive days. They didn't see a difference in GI side effects between the doses, so it's not thought to cause any harm. So overall, I think what this small study does is sort of reinforce my current practice regarding given oral iron on alternating days. I think the limitations here still exist in that this is a small study. They didn't actually follow these patients out to see what was the impact of resolution of anemia. So I think we would love to see a larger, more clinically based trial to sort of confirm this practice, but my sense is that we're on the right track, and I will probably continue with my less is more oral iron approach. So our second quick take article is regarding smartwatches diagnosing atrial fibrillation. So this also caught my eye because I am encountering more and more frequently these days, and I anticipate many of you may also, patients who come in with their chief complaint of my smartwatch told me that I'm having an arrhythmia. And that's happening more and more, and I think that's a reality of our current existence and codependence with technology. So this article was published earlier this year in the New England Journal, and the design of it is really unique compared to the other studies we've talked about today. So this was sort of a big data type of a study, and it was actually sort of run, and the data is owned by Apple, the company Apple. The cohort here is 419,000 American adults, at least 22 or older. They all had to own an Apple Watch and an Apple iPhone, and the reason they got invited to the study is if they downloaded the Apple Heart app. So when they downloaded the Apple Heart app, that would initiate a consent or an informed consent process where they would learn about the study, and then they could decide if they wanted to opt in or not. They did try within that app consent process to exclude people who already had a diagnosis of AFib or were currently using anticoagulant or who had previously used anticoagulant. If the patient went through the e-consent, then the irregular pulse notification algorithm would be activated. So while they're wearing their smart watch, it would generate these tachograms, which would basically be these 1-minute pulse assessment evaluations. And if an irregular pulse was picked up during those tachograms, that would be sent to this data monitoring center and generate a telemedicine visit. So a provider somewhere would call that patient. First of all, they'd make sure that they were stable. If they weren't stable, they'd tell them to call 911. If they were stable, they would talk to them more, make sure they didn't already have a diagnosis of AFib and were willing to participate further. And if they were, then they would be mailed an EKG patch, sort of like a Zeo patch type device to wear for 7 days. So what did they find? So over 117 days of monitoring, about 2,100 participants were found to have an irregular pulse notification. So that's actually a reasonably small percentage of that giant 400,000 plus cohort, about 0.5% of them. And of these, 450 ended up returning the 7-day heart monitor patch. And some of those 2,000s were excluded because A, they already had a diagnosis of AFib, or they were unstable, or they didn't want to participate. So that's why the number shrunk down. But basically 20% of those invited returned the EKG patch. And of those who returned the patch, they found AFib in 34% of them. So a really non-negligible number of new AFib diagnoses here. 35% of the rate was 35% adults who were older than 65, but there was also a significant number found of cases of AFib found in patients less than 40. They also looked at, for people wearing the patch, what was the positive predictive value of that irregular pulse notification being concordant with AFib at the same time on their Zeo patch type device. And when that was evaluated, it was actually 84% of the time that that pulse tachogram actually found AFib. Now, them calling that positive predictive value sort of bothered me a little bit because I don't think that quite jives with my understanding of that term. So that's certainly not the positive predictive value in this whole cohort of 400,000 plus patients. But what I take away from this is that we really can't ignore people getting irregular pulse notifications on their smartwatch, and that especially if it's a patient who does have some cardiovascular risk factors, I'm going to take this pretty seriously and probably beyond getting an EKG, very seriously consider getting a cardiac event monitor. So I guess I'm saying technology is not all bad, and I do think we need to give it some credence given these findings. That being said, this is in no way a type of study design that we're used to basing a lot of clinical decisions on, but I think we're going to see this more and more. So I'll turn from that, and again, we'll take questions on each of these 3 trials just at the end here, which is the sunscreen trial. So this, I think, received a lot of headlines earlier last year when it was published. And this is a JAMA article that came out regarding what is the effect of sunscreen application on plasma concentration of sunscreen active ingredients. The background here is that we know regarding mineral-based sunscreens, so those whose active ingredient is titanium oxide or zinc oxide, that those really are not being absorbed, and they give you that lovely mime-like appearance on your chalky children's faces, like my kids sport all the time. But when it comes to chemical sunscreens, there has been some concern that the chemical ingredient, active ingredients, are being absorbed to a level that may cause some systemic consequences. That being said, the FDA had previously sort of set a limit where if the systemic absorption was lower than that, then there would not be a need to do safety trials for those ingredients. And this trial was really designed to see, are those ingredients being absorbed to more than that preset safety level. So this was an FDA designed and conducted randomized trial. They recruited 48, bless their heart, healthy participants who agreed to come into a laboratory setting and live there for 7 days and be randomized to one of 4 different types of sunscreen preparations, which they were then administered in a brutal fashion. Some of them, again, rating lotion, some different versions of spray. So they were administered the lotion by the study administrators over 75% of their body surface area, which was meant to reproduce sort of the area outside of a swimsuit. They got an administration once on the first day and then 4 times a day at 2-hour intervals for the next 3 days, which is what the manufacturers recommend for these products. Their primary outcome was what was the maximum serum level of avobenzone, which is one of the chemical sunscreen ingredients over this time period. They also looked at all the other common chemical sunscreen ingredients, and they also did skin strippings to see what was the level detected in skin strippings. So what do they find? Well, it turns out every single ingredient that they tested had a maximum serum level measured that greatly exceeded the preset sort of safety limit beyond which you wouldn't need to test further. And in fact, the lotion formulation had the highest serum absorption. It also turned out that all of them exceeded that limit after just the first application. So it really didn't take that crazy regimen of 4 times a day. And they found that the ingredients were detectable in skin stripping samples even at the 14-day mark, so many days after the administration, and even in serum samples lasting to 21 days after the initial application. So what does this mean? Well, it means certainly at this point, we need to turn our attention towards studying what may be the systemic impact of some of these ingredients. However, the authors are very careful to say that these results don't indicate that people should suddenly stop using sunscreen, as there are some risks and benefits to discuss. And sort of with my patients, where I've settled is I may be quicker to recommend mineral-based sunscreen if they're worried about these results, if they've heard about them. Or they could just continue quarantining inside, you know, forever. Actually, I don't recommend that. I do recommend people go outside and walk. So that is the end of the quick take section. So we talked about every other day oral iron dosing reasonable for patients who have iron deficiency with anemia. Pay attention with reason to the irregular pulse notifications generated by smart devices, and chemical-based sunscreens are being absorbed into the body. We don't know what that means. All right, so I'm going to pause there and try to study the chat if I can do so cleverly here. I also forgot to mention, but we do have summary slides that summarize all of the take-homes from each of our articles, as well as all the articles are listed in our reference section. So,
and I didn't see any big questions from the chat about your section, although John and I both agree that their statistics were squirrely from
oh yeah,
smartwatch, but I think point taken. Point taken. I'm wondering if people would be willing to turn on their videos really quickly, if you have one.
Oh, yeah.
Just want to see everyone's face. I just miss you guys a lot. It would be nice just to see everybody if you're still with us and you're willing and you're like dressed from the waist up. I was just commenting to John that it's so weird to talk into a vacuum.
It is.
So I don't see anybody turning their videos on. Maybe I'm not looking. Oh, here we go. Oh, beautiful faces. Nancy, Alice, James. Oh my gosh. I love you guys. You're amazing. James, are you in bed? You're like, you're so like Burt Reynolds in Cosmopolitan magazine circa 1984.
My wife and I have a small apartment and both have multiple meetings today. So if you're not
that's your space.
If you're not talking about during a meeting, you're in the bedroom. If you're talking about during a meeting, you get to be at the table.
Yeah, okay, I get it. My husband and I are in the same boat. We have like one room to be in, and both of us are like on Skype or Zoom calls at the same time. It's not a good thing. Well, I miss you guys all, and I appreciate you being here. Are there other questions for us? There looks like some more messages here. And I want to emphasize that as I was looking through these things to review what we had done, because we made this presentation a couple of months ago, that I actually think of you guys as a much more sophisticated audience as the people this was originally made for. And so I hope this wasn't too redundant for you. But I also think that speaks to how highly I regard all of you. Dylan.
Marianne and Anna, will you guys send me the PowerPoint so I can upload it to the website in addition to sending out the recording?
Mm-hmm. Absolutely.
Yes, okay. We will do that. We have a version that's handout friendly, previously made for ACP, so y'all get to benefit. Yeah.
We also have a pre-recorded PowerPoint, but that would be extremely boring for everyone. So Dylan has a really great point thinking about how many thromboembolic events were prevented by the Apple Heart study. And so we don't really know how many of those would have been detected, but if we assume that none of them would be, that's a pretty significant number. I actually have a patient who showed up to Roosevelt Clinic and saw Teddy Curran because his smartwatch told him to. And he was diagnosed with low AFib. And Teddy and Gabby called me and said, hey, we've got this guy here. He's yours. He's got slow AFib. What are we going to do about it? And we got him started on anticoagulation that day. So my N of 1 of this happening was a real result.
Yeah, I
thanks
entered
to
this
Teddy
with
Curran and Gabby.
I entered that article with a lot of skepticism, but I came away being like, no, this is probably legit. For some of our folks, it's not to be ignored, that's for sure.
Marianne and Anna, we had one with Alan Tsai as well.
Okay.
At Roosevelt.
Yep.
So our ANIC data is very positive.
ANIC data.
All right. Well, we were going to log off. Oh, sorry. Were there more questions? Oh, Dylan.
I was just going to say, I actually had a paramedic 2 years ago at the VA who came in and said, hey, my watch, this was even before the Apple Heart study. I don't know actually how he found this, but he self-diagnosed with AFib based on his Apple Watch. Pretty cool.
Very cool.
Cool. Well, thanks everyone. Anna and I are happy to take emails, comments, virtual Rotten Tomatoes, whatever you feel you need. And we look forward to seeing all of you and high-fiving and hugging in person when this is all over.
Thanks, you guys. We appreciate you.
Thank you, everybody.
Carry on with your ambulatory goodness.
Yes, keep on keeping on.
Thank you, Anna and Marianne.
Thank you, Sarah. You're wonderful. We love you.
You guys are the best.
Oh, thank you. Oh, podcast, yes. I think somebody's already doing that and probably better, but Anna and I find ourselves very entertaining, so maybe someday.
You two would actually be a really good podcast.
Curbsiders